of many people from when they were still in school, or they were. If we can fill these open seats and to be counted. So let's have about it's your government. I think we were settling in nicely. So allow me to Rule 56, just to declare this precinct are expected to carry themselves. So that is in relation to conduct. So he will have just one singular interaction. I really hope all of us can understand. Also makes a feature, because beyond well, of course we are a multi-party committee. So what a body test who this morning have managed to innovations, some of the interventions as it relates, some of the interventions as it relates to this critical subject, all of you, and state who hasn't one called to come to the fore, and who hasn't one called to come to the fore, and you would have availed yourself. We really want to appreciate. You would have availed yourself. We really want to appreciate. We don't take it for granted. But I just quickly want to introduce them, and I know I'm also joined by illness portfolio them, and I know I'm also joined by illness portfolio committee. But I'm not alone. I'm with a beautiful lady here who's alone. I'm with a beautiful lady here who's and a metembegile. So we're anchored by women, and then at the far MCs. So we're anchored by women, and then at the far MCs we are quite fortunate because we are graced by. We are quite fortunate because we are graced by the awesome.
Good morning, everyone. My name is.
The awesome.
Good morning, everyone. My name is Wonderful Sukhuludi.
Good morning, honorable members, MMC. Good morning, honorable members, MMCs, officials present, and also
the acting director for
officials present, and also
the acting director for maternal child health and nutrition.
Yes, isn't it? From
Child health and nutrition.
Yes, isn't it? From the spread of our province, different. Yeah, maybe let's do it. Do we have our province different? Yeah, maybe let's do it. Do we have a roving mic? Yeah. Languages with the potential. Yeah. Languages with the potential of having. For those of you who might want those services, listening in on English, which will be on channel number 1, on English, which will be on channel number 1, and then for those of you who might prefer Afrikaans, it will be on channel number 5. Those of you who might prefer Afrikaans, it will be on channel number 5, channel number 4. So maybe let's quickly check. Are there anybody? Channel number 4. So maybe let's quickly check. Are there anybody? Yeah. I think load. Yeah. I think load. Let's go. Yeah, you are. Yeah, you are enjoined by the Constitution to express yourself in any language. Constitution to express yourself in any language. So if you can just help out in your seat, I get it. Because we don't want to help out in your seat, I get it. Because we don't want South Africa. South Africa, 7 years. With a potential maximum 7 years. With a potential maximum. We've requested in that Mazibuko from a dinosaur. We've requested in that Mazibuko from a dinosaur. We want it to be more meaningful. With a measurable, want it to be more meaningful. With a measurable.
Molweni. Molweni.
Good morning, everyone. Good morning, everyone.
Specialist for the districts for the West Rand districts. Specialist for the districts for the West Rand districts.
Manager for maternal, neonatal, child, woman, integrated school health and adolescent and youth friendly services. Maternal, neonatal, child, woman, integrated school health and adolescent and youth friendly services in the women's health, integrated school health and adolescent and youth friendly services.
Good morning, colleagues. My names are Dr. Good morning, colleagues. My names are Dr.
My name is Maureen Lawrence, the director for NEST. My name is Maureen Lawrence, the director for NEST.
Family physician for Western Area Sub-District. For Western Area Sub-District.
Sanbonani Ututuma Baso operate. Sanbonani Ututuma Baso operate.
As part of our stakeholder, a registry, standing, and the kind of tonality, and how you pitch it. Because now you might confuse the people. So do we have a heads of delegate? Is there anybody? Okay. Maybe let's hand over the mic and then we take those so that we know who's here.
Morning leadership, all protocol observed. This is the Reverend Zex Charlie. I'm the chairperson of Rand West FPO, also a regional convener for West Rand for Progressive Pastors Council of South Africa. Thank you.
Thank you very much.
Good morning. My name is Bishop Lubeko. I'm from MCMC Mogale City, Consecutive Conversation. I'm a PR there. Thank you.
Good morning, everybody. All protocol observed. Coordinator for Rotanganeza Community Care, which is part of the PLHIV sector in the West Rand district. Thank you very much. Good morning, everybody. All protocol observed. My name is Mpo Calvin Mahlaula. I am currently from Rotanganeza Community Care. I've been designated by the West Rand District PLHIV sector. Thank you very much.
All right, thanks. Is that all? You want to stand up maybe formally?
Good morning, I'm Bongani Masbugo, Provincial Secretary of Dinosa and Gauteng.
Yeah, I know we had invited quite a great number of stakeholders, but I suppose we can work with those that are here. We are starting, the program will take off because we are yet to do many of these interactions. But thank you very much. Let me, having taken all the introductions and knowing who is here, I suppose other people might join us in the course of the program. Allow me at this stage to maybe give an overview, but I know beforehand there's a number of apologies, including that of the MEC. So the MEC was scheduled to join us, but there's a premiers coordinating a forum meeting, so the MEC will no longer be joining us. I'm learning that the HOD will be joining us in the course of the day. Hopefully he manages to come on time so that he can pick up on the inputs from stakeholders. And then there's obviously several other members of the committee who also could not join us, but I would not state their names. And then maybe just to bring you up to speed in respect of what brings us here, as we now commence, is that the committee, as an oversight body, ordinarily would assess the performance of the department around a number of clinical programs. And one of them happens to be maternal health. Of course, extended child health as well. And in our assessment, which is done quarterly, and of course, our overall reading would aggregate our observation, over the 4 quarters, ultimately crystallizing into an annual performance report. And what we have detected as part of our oversight is that there are some areas of improvements in respect of the overall maternal care and management, but that there are also deficiencies. And so the committee, in its collective wisdom, thought, well, let's come closer to this program. And of course, in coming closer to the program, we picked up that possibly how the program is managed may lend itself into different variables that often at times might evade, a comprehension around both inputs as well as the outputs. But I suppose one of the things that accentuated our focus on this specific subject was the record of the number of deaths that the committee will have observed through multiple reports, not only just a singular report. And of course, in our reading into that, we thought, well, at the instance be giving birth is a tragedy. Even a puerperium, we just thought this is a tragedy. And this is the committee taking a keener interest to come to this subject matter and disquisition. But of course, having gone through a number of reports, Stats SA has got its own representation. And then the Department of Health at the level of the province will also give an account of the number. And so at some point we interacted with the national department around trying to understand the landscape, which is the overall maternal health care, with a specific focus on maternal mortality rates. And when you have regard to Stats SA, it says to us, well, there are significant milestones from where we were when the country was, democratized, all of a sudden systems were put in place to really try to fashion responses to the rising crescendo of maternal deaths. But that there's a fluctuation periodically, and we may not necessarily get to fully appreciate what are some of the causal factors. And of course, those that are in the know are yourselves who are here, who will enlighten us. And so we looked into the report by Stats SA, which says, well, there's a decline. And of course, I drew a contrast with a global trend. So South Africa is faring well, but we're not out of the woods. We're still not out of the woods. Notwithstanding the many interventions made, notwithstanding the development of strategies to mitigate, we're still not in the woods. And Gauteng in particular, being a central province, and you know, the illusion of Gauteng is that we usually estimate the population of Gauteng to be around 15.1.2. But the distortion around it is that there's a lot of movement in and out. So even when you generate your stats, they might be a bit elusive. Other people might not be accounted for. But we moved past the Stats SA, and I think Stats SA at some point said we have done well. We're standing at about 88.6. That was there, Those are yesteryears. And recently, it gave a record, I think, of 100.6 per 100,000 live births. And we thought, well, let's contrast it with the reports that ordinarily will receive from National. And so with National, they've got the NCC EMD, I think the National Committee on, what do you call? Yeah, the National Committee on Confidential Inquiries, isn't it? So they do those inquiries for any reported maternal death. And so they do an aggregation of the numbers. And of course, it also gives a computational representation. Sit. And what you will find is that a number of these deaths are usually reported through that mechanism. But of course, second to that is that there's also the district health information system. So ordinarily at the level of the districts that we have, facilities would almost immediately give an account of records of maternal deaths through that mechanism. And what we found is that there's a variation between the two. And I know the latter one would be audited. There's another system that they have, a maternal morbidity as well as a mortality auditing system, MAMAS. They call it the MAMAS. Safe to say that the committee made an observation that there are these variations, which instead distorts the overall catchment computation of the actual numbers of maternal deaths. And so the committee resolved itself that, well, we are not experts in the specific field. Let's arrange a session, a forum, where we can have a pool of those who are within the specific discipline to really unravel to us what are some of the notable challenges. Because of course the data also affects the planning. It affects quite a number of other things, including our outlook on budgetary expressions. So if your data is distorted or falsified, it might mean, a representation of what might appear may not necessarily be taken as may be the case. And so that is why we thought, let's come to this platform, And I think one of the elusive things about how we record is that we usually use percentage base points, baselines, which are in themselves can also be misleading, And so we tracked, I think, with a report coming from our provincial department, which are places, and I think also backed up by the DHIS information, that there's a decrease in Gauteng from where it previously stood, which was around 121, if I'm not mistaken, to now 107. And there's a decimal there, 107.6, if I'm not mistaken. So it gives her that representation. Stats say now. In fact, even national, they say 100.6. So it is of maternal deaths. And so we're raising this because it's still a significant and has got a dot. That's why we thought we really need to engage on this specific issue. But of course, statistical analysis, we looked into several reports, dire strain of maternal deaths. I've already mentioned that which also gives a number representation to a greater extent. But of course, to be done, to turn the situation around, to maximally mitigate. Because we may believe that it's okay that we have lost close to 1,000 mothers. Because of how we numerate, how we denominate the numbers, and how we set our targets. We may think it's okay, it's not too bad. Especially when read against the 100,000, live births. But a loss of a mother, and like I said, at the instance of giving birth, affects a multiplicity of other things that relates. This child, it's a matter that the committee will have other reporting platforms. And one of the reports that we encountered was the Saving Mothers report. And I think the recent one, I'm not so sure whether there's a 2024 one. I recall the last one that I saw was the 2020. You will correct me. Is there a recent one? 2023, I'm correct. And the 2023 Mothers report, I think, prescribes about 10 recommendations. And the first of the recommendation, it says, go back to the 2017 because therein significant and elaborate recommendations will have been made. And just at the point of actualization, there was disrupted, and all of you would know that COVID disrupted the actualization of a number of program interventions. And so that is when we started to see a loss of data in respect of the ability of the health system to record inaccuracy, the number of mothers who perished, during that period, perished whilst about to give a birth, perished having given birth, perished in the later periods after having given birth. And we thought, well, this report and the recommendations thereof are quite crucial to premise our reflections on the real state of maternal child health. Maybe we must link it, we must marry the two, because the mother does not exist separate. So there's no insulation between the child and the mother. In the practice of law, you have got something called an asciteras, a fiction. A child, even still in the womb of their mother, can be deemed to be a human being. I'm not so sure. The law evolves with the time. And so we thought, let's come closer to understanding what these recommendations sought to do. And I know we really need to prioritize the maternal health. So that would be one of the overarching recommendations. And then secondly, as well. And then thirdly, it also spoke about and I know one of those interventions which are programmatic would be what we used to call, prevention of mother to child, but recently called the vertical transmission prevention. So that on instances where there could also be other complexities, such as HIV, TB, we also surface those. And then another intervention is that there would be high-risk women who present in our facilities, So the review of CD4's results, so that you monitor and mitigate those kinds of complexities. And then thirdly, minimum standards, particularly as it may relate to delivery, overall and management, as well. And of course, the establishment of medical obstetric units, particularly in our regional as well as tertiary facilities, on to instances of patients who are presenting at our facilities with might require multidisciplinary medical care, And of course, extended to that would be counseling of those who have conceived, so that if needs be, that we for them, particularly as they may present with the complexities. At least the health system would be able to cushion them. And so there's a number of these recommendations which are made in aggregation. So I'm not only just raising those that are in the Saving Mothers report, including in the triennial. I appreciated the leading causes, and we know what the leading causes of a maternal deaths are. It could be hypertension, of causal factors. But beyond those, there are also systemic causal factors. Just the delivery platform, the design of the delivery platform, how those are designated, who assert themselves and state that, well, they had a daughter, the daughter checkups. In fact, the daughter or the family stays rather closer to one of the clinics, Opened an obstetric unit, in that facility, fully no shortage of personnel. And the family says, well, the most peculiar thing is that our daughter would regularly, do before the facility. notable complications were recorded. So this is the account of the. But at some point, I was called out of the room I was in. And so you can imagine the right on the family, including the community. And so ordinarily the community took to the streets in El Dorado Park. Similar, well, not so same, but similar. Is it a system of these patients? You know? But if it's a systems issue, I really believe that in instances where there might be multiple morbidities, the health system should intensify its efforts to mitigate. But of course, I think what we appreciate is that it's not in all cases where you may succeed, but we want that the system must succeed. In hindsight, when we reflected, around why it is necessary that we have this engagement with, we want to get a sense of whether these recommendations prescribed in including our reading of, I know there's a national strategy, it's all encompassing, it speaks about women's health, but if you zoom in close, I mean, maternal health also features prominently there. Whether the recommendations, and maybe it might have been more interesting if we had a representation from national, so that we also, secondly, to check whether we have got the requisite, skilled personnel to be able to translate these recommendations into meaningful actions. District manager programs are maternal as more, yeah? Those programs are there, But thirdly, particularly those who are in the cold phase, what happens in the delivery platform against how those who constitute the layer of get to plan for the resourcing of specific programs, So we thought we want to hear from yourselves. Ronald Duzimo, we only have one doctor, Dr. Mugonot. You see? So we're not experts. Yes, we invest ourselves in reading, but we may never really get to fully appreciate. But because we're an oversight body, we want to hold the department accountable for the kind of interventions that are really necessary. But we are unable to do that if we may not have a full-on appreciation of the social milieu of this medical discipline as it relates to maternal deaths. And so we really want you to engage on this subject with an open mind so that we can conjure up the right kind of solutions. Of course, our limitation is that we will try to be transcendental in our reflections. But where we may reach, it's within the environs of our province, where we can be able to reshape the outlook, the discourse around what needs to be prioritized. Because as we are seated here, beyond the playing oversight, it is us who approve budgets. It is us who place scrutiny over departmental programs. But when you don't have a greater appreciation of the essence and content of what should be you find that a whole lot of things fall through the cracks. And that is why you are here this morning. I know I may have taken a bit of time, but I just thought let's unravel the basis around standing in front of all of you this morning, so that collectively we can converge, referenced. We believe that in the immediate, these interventions. In the intermediate, these are the steps or interventions. And in the outer years, these are some of measures that you can employ to really mitigate the ravaging effects of maternal deaths. I did say when we start that a loss of a mother at the instance of a giving birth is a tragedy. And so we want this conversation to assist us, that we reduce, we minimize the extent of the tragedy. Allow me to leave it at that. I really hope that we'll have why we are all here this morning. Acting that a lot of acting. Maybe one of the contributing factors, it's acting. You know, there's a lot of acting. We are acting a lot. There must be a threshold for acting. We can't have the whole institution acting, you know. So our director here, let's leave out the adjective acting. Our director is going to navigate us through a presentation, and then immediately thereafter, we'll invite the participation of our stakeholders, including some of the managers who are here. Thank you very much.
Good morning, everybody. Just a sign of respect. Thank you very much. It was on. I indicated that my name is Marosi Mzondi, and I don't want acting, but Acting Director, Maternal, Child and Women's Health, going to present, if you allow me to do so. Thank you. Where the NCCMD looks into the causes why these women died, and this, yes, that's why they are calling it a triennial report. So we have a few achievements or best practices that I'm going to mention here. There are a lot, but we just selected a few. So we are having we increased total number of choice on termination of pregnancy facilities, which in 2024. Maybe you'll ask yourselves why we are starting with this is because abortions. So that's why these facilities are opened for safe termination of pregnancies. And then this is for the first trimester or the first, and then for the second trimester, CTOP, choice on termination of pregnancy hospitals, they have increased from 9 in 2022 to 12 in 2024. Oh. Can they see? Okay, thank you. Sorry about that, yeah. Okay, so I was on the second bullet. Yes. Okay, I'll start with the first bullet that spoke to the fact that the department has increased the total number of choice on termination of pregnancy facilities from 41 in 2022 to 45 in 2024. And as I explained, that these facilities were opened because previously we had a lot of women that are coming to our facilities with what we call septic abortion, and those caused a lot of complications up until these facilities were opened and are deemed to be safe places where this choice on termination of pregnancies can be done. And then for those who have reached the second trimester, COTO 9 in 2022 to 12 in 2024. And then we also have established a health soft border forums with neighboring provinces. Why we have established that is because, as you know, Gauteng has got borders. We have a border of northwest, for example, in Swani, northwest Mpumalanga. We're having those patients who are coming into Gauteng, mainly because a street across from Gauteng to that province. So we have formulated this forum where we are meeting to discuss some of the challenges that we are having. And then we have also expanded expansion of limited obstetric ultrasound outreach services, where we are having even the midwives that are providing ultrasounds to our pregnant women. And then we've also improved performance on antenatal visits before 20 weeks of pregnancy rate, because for each and every pregnant woman, we encourage that once a woman identifies that she is pregnant, we encourage that they visit a health facility, because if they visit a health facility, we will be able to can identify any problems or any complication early enough and will be able to attend to them. And then maternal death notification application has been introduced in health facilities to strengthen the maternal death reporting system, so that if there is a maternal death, they just use that tablet to inform the provincial office that there is a maternal death. And then we also rolled out the pre-exposure prophylaxis, which we call the PrEP, and post-exposure prophylaxis in pregnant and breastfeeding women. Because with the PrEP, we know that is that a tablet that is taken when you are HIV negative, so that you protect yourself from being HIV positive. With PrEP is the treatment that is taken after any eventuality like rape, so that you're protected from HIV. And then the next slide, I moved to the wrong direction. The next slide is talking about the deaths. Thanks to our program manager, he actually went through and gave us a good introduction of our presentation today. So he also spoke to the maternal deaths. So I'm going to reflect, or we have reflected, those that happened from 2021 up until 2023. So these deaths, whenever they happen, we are recording them in our electronic system, which we call maternal deaths on district health information system. And these are deaths that have occurred in our hospitals. That is why in brackets we've written inpatient maternal mortality ratio. Though here we have written them in numbers, and it is indicated that these maternal deaths in 2021, we had a total of 341, and then if we all remember this year, it was just post COVID-19, and that's why the numbers are so high. And then when we come to 2022, those numbers got decreased to 266, and then in 2023, they went down to 217. And then all the maternal deaths that are reported in our health facilities, they are assessed. That is, any institutions that has a maternal death, they are encouraged to sit down as a team of midwives, obstetrists, and gynecologists, the nurses in that institution, to look at what are the causes of that specific maternal death. So we encourage that all the deaths be assessed, and in fact, for us to can know what are the causes of that maternal death, for us to know what can we do to prevent similar occurrences. So that's why we are assessing all these maternal deaths. And then this slide is talking to the progress on implementation of the recommendations, which is what we are here for. And with the first one, okay, they have been, you know, rewritten. So the first one is looking at contraception services need to expand to include postpartum intrauterine contraceptive devices. This is talking to women who have given birth, and it is encouraged that they be inserted the contraceptive method called the IUCD, intrauterine contraceptive device, immediately after delivery or after delivery. And this is one of the long-acting reversible contraceptives that we are using in our health facilities. And it's also saying ensuring contraceptive availability at all facilities caring for women at high risk medical clinics. And then the progress is that we are also having one type of long-acting intrauterine contraceptive device, which is called an implanon, which is inserted to women post-delivery. And then also, we have also noted that there is no shortage of intrauterine contraceptive devices. And in all our health facilities, we are having all different methods of contraceptives that women can use. For example, the oral contraceptives, the injectable contraceptives, these long-acting contraceptives, which is implanon, and contraceptives that allows women to have a broader choice of a method. And then we only don't look at the choice of the woman, but we also look at the condition of the patient after being examined. And all these go along with usage of a condom. And then the second recommendation, establish a safe labor criteria and evaluation program like a safe cesarean delivery, that is surgery and anesthesia program, and maintain focus on the safe cesarean delivery program. So the progress on that is that we are having a tool for evaluation of hospital compliance with the minimum standard of safe cesarean delivery. And we have received, there are forms that hospitals are filling in, and we have received 19 out of 23 hospitals, and we are still following up on the 4 that are remaining. So with this form, it allows the hospitals to actually go through the form to identify if they are having everything that they need to have before a surgery or cesarean section can be conducted. For example, do you have an anesthetist? And we know that if there is no anesthetist, if there is no anesthetist, an operation cannot continue because complications can come into place. So the other one, establishment of on-site midwife-run birth units, and in abbreviation, we call them the OMBUs within the hospitals. It is encouraged that these OMBUs be there within the hospital premises at all large district, regional, and tertiary hospitals. And these OMBUs, it is said that they will solve the overcrowding in hospital maternity units and alleviate the burden in busy hospitals. So with progress, okay, we have identified 7 hospitals that are lifted there: Sebokeng Tembisa, Leratong, Dr. George Mukari, Kalafong, Mamelodi Rahima Musa, Mother and Child Hospital, and the province is in the process of developing the MBUS, which needs development from the terms of reference. And actually, the various hospitals have done an exercise of identifying the space where this can be placed, and because this will actually assist. And if OMBUS are there, for example, if it is at the next to the gate of the big hospital that has a taxi rank next to that hospital, women who are high risk, who are pregnant, will be taken care of in that OMBU, and as soon as they have any complication, they will just be wheeled within the hospital to the delivery unit. That's why we are saying they have to be in the hospital. Okay. And then implement the updated vertical transmission prevention guidelines for better HIV management and TB detection. And then we said all facilities within the district have vertical transmission prevention guidelines, and these are implemented. And we are training and mentoring our staff, and this is ongoing in all health facilities with the assistance of the district clinical specialist teams that we are having in all the health districts. And then the national standard operating procedures on TB screening and testing is available and utilized in these health facilities. And there's also random clinical record audits that are conducted on quarterly basis to identify areas of improvement in order to improve on quality of care. And then the next recommendation is the one that is looking at ESMO that our program manager spoke about, and the full name for that is Essential Steps in Managing Obstetric Emergencies Training. So these trainings are ongoing, targeting the newly appointed staff, and these are continued on 2 yearly updates for previously trained staff at health districts and hospitals, and even as and when we see them needed. Okay, let me come to progress. All districts are conducting these ESMO trainings.
I'm sorry to do this. There's a car, and it's obstructing. Somebody else's car wants to leave. It's a silver Audi A4. It's JN167GP. You come here. Yeah, I'm saying there's a car, a silver Audi A4, which is obstructing another car that wants to leave. I think the registration is JN167. If you could just maybe move the car. Silver Audi A4, if that person is here. Thanks.
Okay, all right, thank you. Trainings that are ongoing in all the hospitals and district clinical specialist teams, and there are also in-house trainings that are conducted, especially for the hospital staff and the medical interns. And expected to perform cesarean section are also assessed and accredited by a specialist perform a cesarean section on a pregnant woman. The next one, prior to discharge from a ward and facility, specific criteria must be met and documented on the discharge summary sheet of a patient as per the maternity case record. Progress on this point is that all women who are ready for discharge are rated according to the pre-discharge checklist, and if the discharge criteria is met, a discharge summary form and the education pamphlet is given on contraceptives and the list of danger signs that this woman should look during the postpartum period or after delivery. So that form is issued to these women. And then all women leaving the health facility, leave the health facility with a contraceptive method. Health education is given, encouraging them to have a method. And as it was mentioned earlier, we are encouraging them to use the long-acting reversible contraceptive method. And in this place, those that are agreeing, an implant is inserted on them. And then as indicated, there are also other methods of contraceptives, pregnancies. And then there's a recommendation again that says set up an expert group to recommend on improving the management of early pregnancy districts. As we know that the districts are not the same, so as we are working, we look at which district is performing. Of Circular 1 is also implemented, Circular 1 of 2020, that because we don't want to see a situation where if a midwife is trained on ESMO, the next thing she is moved going to implement or use that information that she got. So this of experienced midwife offering antenatal services. Okay. Health soft border forums, the one that I spoke to earlier, that we are meeting with the other provinces that are forming a soft for us to can talk or identify health problems that we have as the similar based on termination of pregnancy services, we spoke about in the first. Also implementation of the lean management, and this is, it was first implemented in one of the hospitals, Leratong Hospital, and this looks at the best practice and achieved with limited resources, where staff is, congratulated or encouraged to do their best in everything that they are doing. And then progress. Recommendation, all maternity sites must continue to conduct what we call the M&M meetings, and M&M stands for morbidity and mortality review meetings, and follow up on quality improvement plans. Pediatric units and district hospitals, these M&M or morbidity and mortality meetings are being conducted on monthly basis in these district hospitals. And they are also conducted in regional and higher levels hospitals, and these are conducted on weekly and fortnightly basis. And then the district-specific M&M are also conducted quarterly, because at district level, these women, including them in these M&M meetings, those nurses at primary health care clinics, because they are the ones who have spent quite a long period during the 9 months looking after these women. So when we conduct these, encourage that they also join, and they also have their own M&M meetings. So progress on that one. Intervention for women in need of these services is implemented. Mental health assessment tool, which is provided in the case record in all primary health care facilities and hospitals. So it's important to identify if that woman has problems that will need to be attended to immediately. And then identification of high risk complicated pregnancies to be discussed with doctors from referring hospitals of patient. So with progress, non-urgent hospital. And then emergency high-risk patients are so that appropriate care can be assigned for the patient depending on her condition. And so that challenges, okay, those were the recommendations that were written, and progress on those recommendations. And then the other thing that we requested to do is to present maternal deaths and the solutions, how we are preventing those maternal deaths. As indicated earlier, one of the challenges or one of the causes of maternal death is postpartum bleeding after delivery, and this is still a cause of maternal deaths. So what is the remedial action? We are giving or providing the supplements that we call iron to all women who are pregnant in order to prevent them from being anemic. And we also check the status of anemia when they visit our antenatal care clinics. And then we also comply with the minimum standard to deliver in hospital, with the minimum standard to deliver in hospitals where theater is available, that has a theater or theater services. And then hypertensive actions, we are saying prevention of hypertension by providing calcium carbonate is very important, and issuing of aspirin to all pregnancy in order to avoid these hypertensive disorders. And then we are continue with the in-service training on hypertensive disorders to all our midwives and the nurses, doctors of continue with the in-service training on hypertensive disorders on pregnancy at all levels of care. Healthcare level, and then throughout all the other levels of hospitals, also in the community through our health promotion, health education need to be given to the community at large. Hypertension disorders and women with chronic hypertension, women with gestational hypertension and pre-eclampsia are advised to attend antenatal care at hospital and then the other challenge is delay in transportation. Can I take a sip? Okay, thank you. Hey, it's a marathon. Anyway, coming to this challenge, transportation of complicated cases to higher level of care. Our remedial action is that we continue to train the staff on ESMO. Remember, ESMO looks at emergency cases in order to identify complications early enough and for them to refer these patients needing referral to higher level of care timelessly so that they don't waste time trying to take care of that woman. Meanwhile, she has to be referred to a higher level. And then we are saying escalation of policies and standard operating procedures are available and implemented. Okay, and then also they launched new ambulances, for sure you saw them. The ones that were launched by our MEC for health will also contribute or are also contributing in reducing delays in referral to higher level of care. And then overcrowding in some hospitals is also a concern. So with this one, we are saying patients who are at low risk are referred to primary healthcare level in order to avoid overcrowding in the hospitals. And then there was this question of linkage between triennial reports and medical legal cases arising from maternal health related incidents. So with this one, we had to get expertise from our legal unit for them to check for us that from 2017 up to now, up to 2022 of this triennial report, how many cases were reported or legal cases. And then they said from 2018 to 2022, the department has not been served with any legal proceedings related to maternal deaths occurring in any of our health facilities, healthcare facilities. And then the last slide on conclusion, it's saying increasing access to safe termination of pregnancy has reduced the number of maternal deaths due to septic abortions. And then all hospitals are striving to reach the minimum standard of safe cesarean section delivery. And then also a task team is established to explore the establishment of on-site midwife-run birthing units, which are called the OMBUs, as I explained earlier. And then with ESMO and in-house in-service training, these are conducted in all levels of care to address management of postpartum hemorrhage, that is hemorrhage after delivery, bleeding after delivery, and hypertensive disorders of pregnancy, as I've mentioned in the previous slide. And then the department will continue to procure what we call the Ilavi balloon tamponade. So this is a balloon or a tamponade that is inserted in the uterus of a woman who is bleeding so that it presses to compress and prevent further hemorrhage. So this and this NASAC, or what we call the non-pneumatic anti-shock garment, NASAC, will continue to procure them in order to address the postpartum hemorrhage or bleeding after delivery. So this was my last slide. Thank you very much, and may the Almighty God bless you all.
Let me try to use this one. Can you hear me? Langudra. Okay. So I think that was the presentation that sought to track where we are in respect of those recommendations. I did say earlier on that these are aggregated recommendations from a number of these reports, Savings Mothers Report, the triennial reports. And I think the department, through this presentation, gives an account of some of the steps that they would have taken to ensure compliance, but also with the intent to mitigate the effects of maternal deaths. At this point, we really just want to, because the main part of why we're here is to really to hear from yourselves. You know, we don't want a monologue. We can't speak to ourselves. You know, so you have got the committee of the legislature and the department, which has given a presentation. We now want to hear from stakeholders, the stakeholders that are here. And I really hope your voices can be counted. We want to hear from you what your experiences are. Some of you might be professional nurses. You could be in midwifery. Others of you might have had encounters with, you know, mismanagement of certain protocols. We want to hear from you. Others might be bodies that represent, you know, an array of patients in our facilities. We also want to hear from you. So we want to hear from all of you across the board what your overall experiences are in respect to the management of maternal health services and how best to reduce maternal deaths in our facilities. And as you do that, we also want that you assist, you know, that in addition to some of the recommendations that would have been captured, what do you believe are some of the more immediate tasks that the department should undertake to really turn the situation around? I know I did say earlier on that we want to have a rounded conversation. And we want you to express yourselves freely in any language, because I know the trappings of language, for those of you who may not necessarily be exposed to medical jargon, might be a bit arduous, it might be a bit difficult. We want you to feel comfortable expressing yourselves anyhow on any specific issue, so long as it relates to the subject matter. I know ordinarily when we say stakeholder meetings, people might want to raise issues which are extraneous to the subject matter. Again, kore kopano ya rona ya general. Re batlo bua no attitude ya nesele. Re batlo focus on maternal deaths. Again, if of course there are attitude issues, you can surface them. But re batlo bua general. Again, re batlo bua generalities. We just want to be more pointed. But allow me before then, I'm not so sure whether our respective MMCs might also want to say something before I give to the members as well as the stakeholders. Could I maybe just hand over to yourselves if there could be a point or two that you might want to surface? You are fine? Okay. So it means the department has done a good job. You have captured the essence. Yeah. So members, maybe let me start with you, and then immediately thereafter we'll then hand over to our stakeholders. Oh, there's something. Okay. Maybe let's do that.
I just wanted to say, I'm having my seniors here, even the chief director from West Rand acting chief director from the province, specialists here. If there's maybe, if you allow it, anything that I have not addressed, or they have a point to raise, maybe can they be also given their chance? Even with answering questions, we are a team here, so we are going to assist each other. Thank you very much.
I think what we'll do immediately after stakeholders, I mean, where there are areas that you might feel were underrepresented in the presentation, we'll give you an opportunity so that you also speak to those. But I just want to start with members first. Can I take members? Yeah.
Thank you very much, Chair. Good morning, Dumelang. As introduced, my name is Matsiriso Mfikwe, ke le leloko la committee. Chair, the presentation, the data ends in 2023. So it would have been very interesting that we get a sense as to what happened up until now, if the data is available, and it's how maternal health has improved up until 2023. We are 2 years down the line, almost, and we don't really have a sense of what is the situation right now. So if the team could give us just a sense as to what now, what is the status. The presentation talks about recommendations. Start with recommendations and progress. Recommendations on what? What is the problem that gave birth to the recommendations? Because then we are left with assumptions. You know, I mean, the first recommendation talks about contraceptive services. Does it mean that this is the problem? Would have been a question asking about the uptake of contraceptives and what else, you know? So it's a good presentation, but they are short because we don't know what you are answering, you know, but we have answers. There are issues that Chair spoke about that prompted this engagement. You know, the presentation is not responding to those concerns that came to the portfolio committee. Not sure if the team that is supporting the acting director would be able to respond to some of the challenges that the Chair has raised. We are here because of the concern of the impact of maternal death, you know, in society and in families. You know, if we still have those cases even now, but our report does not even talk about that right now. So, Chair, that's my concern, that you are responding to something. There's recommendations and progress that we don't know what prompted that. And so for me, those are the issues that probably the team needs to clarify. You know, what is the current status? What are we talking about right now that gives birth to these recommendations? Thanks, Chair.
Okay. Is it Member Evans? You may come in.
Thank you, Chair. My name is Louisa Evans, and I'm a member of this committee. Firstly, this presentation that we have received, can we get an updated one? Because there's information that we don't have here that was shown on the screen, please. And then, Member Mfikwe, thank you so much. You have touched on a few things that I also wanted to bring up. And then on slide 5, on my side, I would like to know this. Let me just go to slide 5 quickly. The on-site midwife-run birthing units, your OMBUS. Right now, I have a few questions. Will this be able to give us clearer data with regard to how many undocumented mothers have gone to our facilities to give birth? Will we be able to know that? Especially seeing that we are in a mining area. And yes, things happen. In our teenage pregnancies, is there, can we get stats on how many teenage pregnancies were recorded per quarter? How many are underage? How many cases was brought against them? Did the department follow up and make sure that legal cases were, charges were brought against these fathers? And yeah, that, for now, that will be all. Thank you, Chair.
I must just caution that we are on maternal health services. I know there's often a temptation to overextend the conversation. Otherwise, we might get lost into what we are attempting to really unravel. You know? So I think as we are cautioning those that are going to come, stakeholders, like we advised earlier on, let's be more pointed. Otherwise, our conversation will be eroded. We will not know what we're dealing with. You know. So let me note from. You want to come in? Is there somebody there? I can't see. You are fine. Is there anything you might want to say, Doctor? I see you have been writing a lot of notes. Maybe let me also give you.
Good day, colleagues. Good day, honorable members and honorable chair. My question is related to the statement that was presented by our colleague that there's no shortage of IUCD, intrauterine contraceptive device. Yet, the report of the department, the recently presented report, the Q3 report, has indicated that the department did not achieve this target of IUCD. The reason being that there's shortage of IUCD. That's the report, the information is in the third quarterly report of the department, and this is what was presented to the committee. So this seemed to be a contradictory information. And again, shortage of IUCD, based on what the department has reported, it's a risk to teenage pregnancy. How is this, how can this be mitigated? And some of the recommendations that were mentioned by our colleague is that the department there must be, or to be done, or they must be implemented, or are to be implemented. And the question that arises is that, are all the recommendations or resolutions by the Centenary reports implemented by the department? If not, which ones are implemented and which ones are not implemented, and what could be the challenges in implementing those resolutions? Thank you.
Okay, so thank you very much. Without being the devil's advocate, I know the report surfaces some of the recommendations from the triennial report. I did say it's an aggregate a recollection of some of those recommendations, both from the triennial reports as well as Saving Mothers report, which is also another a reference, a document as well. But allow me at this stage to invite stakeholders who might want to input on the presentation or any other related input related to the subject matter. Is there anybody there? Yeah, I'll take, who's going to assist? Okay, I'll give you numbers. I'm going to give you numbers. You will assist us again. So let's start with number, wait. You'll be number 1, and Ntate, followed by Ntate Mazibuko will be number 2. Ntate Molo is going to be number 3, followed by Ntate Kamumrao again. Olona number 4. Agar number 4. Rabatla bo mme ba bue man. Why ka re bo mme ba batlo bua so? Ntho a ke re tshwenya lona. We are not dealing with men's health. Although we know that this issue also affects our households, which are led by our men. But we also want women to surface their own lived experiences. Again, Ntate Mole will be number 5. Evan, bomme ale ba tlo bua. Okay, make number 6, me wa ntla ke number 6. Me yona number 6. Is there anybody else? Yes. A ke re tletse lona ka mo. A ra itlela ke re. E ka rona e lo ra le ba tlo bua ra paka re jala ntse ra tsama. A ke re. So ke kopa ba le ba ba tlo go bua go morao. Ba go kae?
7.
Go kae?
7.
Ya e tla mama onna number 7 e tla o dule mo go go le thata. Number 7 wa rona is there number 8.
Number 8. Number 8.
Number 8.
Number 8.
Number 80 mama. Mama will be number 8. Number 9. Where's number 9?
Number 9.
I don't go to Wisagangani. You know our people are so good at complaining, but when platforms are created for them to express and ventilate their frustrations, you neglect these platforms. We are unable to hold the government accountable if you are not going to express what you are observing in our facilities. Some of you have got relatives, who have got siblings who are in facilities which we think might be mistreated somewhere or the other. Again, not necessarily that you must create things which are not there. If you believe you are well treated, it's okay. But if you feel, you know, I had an experience, I once gave birth in this facility, this or that was not done. We want to hear from you. Again, so that will be our number 9. You will be our number 9. Number 10, but I'm fellow. That them we are not number 10. Number 11, you are number 10. Maybe you will come around number 10. Okay, I read an even number. Read 12. Me. Okay, me. Udon na me wabufello agere. Yeah, me wabufello number 12. Ndatolo to chuba tlo bua lwen. All right, okay. So in this round we have got 12 hands. I normally don't want to limit people from expressing themselves. Ne? But we want you to be structured, concise, and coherent. So, is 3 minutes enough? It's enough, ne? Okay. Or 2 minutes? 3. 3 minutes is enough. Agreed? Agreed. So let's start with our number 1. So, how Amela, you tell us who you are, where are you from, and if you are belonging to any civic organization. Yeah. Thank you very much.
Thank you very much, Chair. Honorable members, MMCs, officials, ladies and gentlemen. I'm Cassidy Rangata Jacobs. I'm an advisor, health and social development at Rand West Municipality. The presentation is welcomed, particularly since we've managed to reduce the number of mortalities since the period just after COVID. Maternal health is extremely important. The mortalities, it's extremely worrying, even if it's just one. However, my concern is a mother might leave the hospital and the child might die at home. A day later, 2 days later, does the district have any pathway to care where they are able to track after a certain period? I'm not sure if it's 1 year, 2 years, 3 years until the child is a certain age, where they're able to track the health of the child. Because if the child leaves the hospital, the mother has given birth, the child was alive and well. The mother gets home, the child dies, or the child becomes sick. One of the first things that the mother will do is probably take the child to the local clinic. do we have a mechanism in place to track where it is, and then the clinic would refer the child to the nearest day hospital or whatever facility it may be. But do we as a district have a mechanism to track the deaths of our toddlers and not only our children in hospitals? If not, it would be great as a recommendation because all children lives matter, and particularly today, since tuck shop registrations had to cease or happen by today, we don't want a situation where our children die again because they bought from unregistered tuck shops, and then us as a district, we don't have a mechanism to track. So that's my submission. Thanks, Chair.
Thank you very much. Limutulo rontato representi like arze number 2.
Thank you. Morning, everyone, and all protocol observed. My name is Bongani Masbugo, Provincial Secretary of DINOSA in Gauteng. Thanks for the presentation. I'm just going to touch on a few issues from the presentation and just make a few recommendations as well. Firstly, the issue of recruitment of skilled personnel. It is a challenge. We know that there is a shortage of nurses and shortage of skilled nurses as well, advanced midwives. So I think the department needs to be doing more in order to make sure that nurses are equipped or assisted in making sure that they attain the advanced qualifications. And the issue of rotation, it's still a concern. I noted that in the presentation they say there's a recommendation that it should be reduced. It should be eliminated. If you've got people who are in midwifery, in the labor ward, you cannot want to, because those people acquire a skill in time as they practice. Now, each and every time, if after 6 months you move those people to a general ward or elsewhere, you are now bringing in people who are not skilled, and that exposes the department, and it decreases the amount of the quality of healthcare that the wives, the mothers are supposed to be getting. So we need to look at that and make sure that instead we retain the people who are already exposed to midwifery and make sure that we equip them in making sure that they get they attain that qualification of being advanced midwives. Assessment of high-risk women. It's either one, there's no proper assessment, or two, there's no proper health education given. Because you keep finding high-risk women presenting themselves at MOUs, at maternity obstetric units, whereby they are not supposed to be there. They're supposed to be presenting at hospitals, as the presentation had said. Now, that places a risk on both the midwife and the mother, because the midwives who are at the MOUs are not equipped, and they don't have the equipment to be able to deal with some of the high-risk issues that the high-risk patient might be presenting with. So that needs to be attended to. The debriefing services for midwives. Midwives deal with a lot. Midwives are exposed to maternal death or the death of the children. But I'm not hearing anything about the department saying what kind of support are we giving to the midwives to cope with this? Because some of the midwives end up having breaking point because they are not getting the necessary support that they need. If COVID has showed us anything, it has showed us the importance of mental health care. And as a department, you should be looking after the mental well-being of the nurses that are working there. The nurses who are working at CTOP, those nurses need to get debriefing on a regular basis as well because of what they're dealing with. It is important that we assist them. So those are some of the interventions that we think the department should be highlighting. And there should also be partnerships with private stakeholders. I didn't hear much about that from the presentation. You've got other companies which would want to partner with the department. So the department should be open to saying that how do we then partner with those people in making sure that we equip the nurses and we equip all the people who are supposed to be dealing with issues of maternal health care. I've got a question as well. You'd find that, let's look at situations like at Rahima Musa, whereby women would come in a bus to say that a number of women would come, 40 women at a time, presented to come and deliver the healthcare services. we are not receiving those reports, and yet our members on the ground are telling us of such stories. And then you'll then find a video being circulated of women sitting on the floor without a background of how did the women end up sitting on the floor. Those women came in with a bus and they come in head-on perineum. It means they are ready to deliver. And now you've only got 3 midwives on duty at that time, at night, because you've got fewer midwives on duty during the night. You've got 3 or 4 midwives to deliver, and you've got 50 or 40 patients who need to be delivered. That is a risk, and how are we going to address that? Because that is an issue, and most of these women who are coming in this bus, they are undocumented, they are not South African citizens. So something needs to be done in order to manage that and take it into account. The M&Ms that are held, sometimes M&Ms are, instead of being learning opportunities, they are used to crucify and vilify nurses or individuals. So there needs to be a proper procedure on how these M&M meetings are managed. Because when you go there, it's supposed to be a learning opportunity to say, we've had a maternal death, or this is what happened, and then we want to learn, how do we stop this from happening again in future? But if you are going to go there and be vilified and victimized, then you're not going to be open, and people are not going to learn anything. So there needs to be a better way of managing these meetings and making sure that they are much more open, and then people are also able to express themselves and give necessary opportunity. Because sometimes doctors do not want to listen when they come to these forums, and they feel that they are the only ones who are supposed to talk. That should be addressed. When we are in a multidisciplinary team, we are all equals. No one is senior to the other because we are all professionals. And we should respect each other as professionals. Almost done. And the referral of pregnant women to facilities of higher care. It's a problem because and this goes together with the issues of delayed transport. We do not, it's either I'm not sure, here I saw that on the presentation, you said that the MEC unveiled ambulances, but we still have issues of a woman having to be transferred from Shawela to Para or to Liliangwe. It takes forever, and midwives at the clinics end up having to deliver those women. It is a risk because you are now putting them at Sank's, at loggerheads with Sank. The nursing council will be waiting for them to say that you have acted beyond your scope because you delivered a high-risk woman and all of that. Whereas the ambulance is the one that took time to come and pick up that woman. And the doctors that are supposed, when the nurses call the receiving hospital, the person who's supposed to give go-ahead does not want to receive the woman because they say they don't have space. So those are issues that the department needs to look into. If there's no space, then what is the alternative? There should be issues of overflow or redirecting to say that if we are redirecting you to this other facility, or the department should consider as well, as you had said, mentioned the issues of interns. There should at least be interns at the CHCs, at the MOUs, in order to assist the midwives who are working there. And availability of medication to prevent anemia. The department is forever short of medication. What are we doing about that? Because if we're not going to give that medication to the iron medication to assist, then we're going to have women who are going to bleed either during or post delivery. And the last one is that ambulances. There should be at least an ambulance on standby nearby the MOUs, or at least in the vicinity of the particular MOUs, so that as and when there is a call to say that there's a high-risk woman that needs to be transferred, then the ambulance should be there within a specified amount of time. In that way, saving both mother and child. Thank you.
Okay. Thank you very much for that. I think there was quite a lot. I hope we have been captured. I see some of the managers, I'm worried that you are not recording what stakeholders are saying, but you are on your phones. Please, let's record. Because we want that at the end of these engagements, we converge around what are some of the actionable items, I did say, beyond what the department is currently doing. So please, let's discipline ourselves to do that. Can we take number 3? But before that, this thing here, there's another owner of a car. Well, there's no make, it just says registration details. GHD 739 GP. GHD 739 GP. If you can move your car, I'm not so sure who that is. And then to our translation booths, these things are not working, and I'm not sure if, I've just tried. You know, they're out of network, so you might want to look into that. Otherwise, they become meaningless if people can't hear. I've just tried, because listening from the wall, I'm also struggling to capture some of the points. So if you can just maybe check what's happening there. Can we then go to number 3?
Good morning again. I hope it's morning. Kalibito, my name is Mogale, and as I've said, I am from Rotanganeza Community Care, and I am the national coordinator. I'd like to also thank the previous speakers for the points that they've made. Honorable members, all protocol observed. I've got a bit of an issue that I was able to pick up because there was a program that we used to roll out within the Western District, which was called the Community-Led Monitoring Program, where we used to just monitor the accessibility of certain services within our health facilities clinics. And one of the things that we found out was that there's a high number of late bookings in terms of pregnancies. So you would find that a lot of mothers would book 20 weeks after, and when the booking is supposed to happen within the first 20 weeks to ensure the safety of the mother and the child. So I think that could also be a huge contributing factor in terms of the amount of maternity deaths that we're experiencing. So I would also like to please urge the department to also look into that specifically. I also have a question in terms of the figures that we are receiving. How many of those figures are representative of the foreign nationals? Because we have a bit of an issue again through the CLM, community-led monitoring program. We were able to find out that some of the foreign nationals that do use our facilities share the same documents amongst themselves. And then when they get there, you will find that you will have to take a file of a person that it really does not belong to, which then also distorts the quality of services that they are supposed to receive based on the fact that we'll be using somebody else's information. So that as well could also be a huge contributing factor in terms of us in the fight of decreasing or rather eliminating mortality rates in terms of maternal health. Another thing is also the language barriers that we are facing in terms of the very same foreign nationals. I think that could also be a huge, huge contributing factor. So I would ask for us to please look into that. I also have a suggestion in terms of the late bookings. If we could utilize some of our healthcare workers, such as teams of your WOBO teams. I don't know if the term has changed. Please do correct me. Those who are in the health department, to help identify, as they are the ones that actually go to the communities, to identify those pregnant women so that they can help them report those pregnancies in due time, so that we can do everything before the incident, the prevention, to take place in the best way possible. Thank you very much for your time. I submit.
Thank you very much. That would be number 3. Can we take number 4?
Dumelang bahaeso. Le tsogile. Le nna ke tsogile. Through you, Chairperson. A pele ke bue hore ke nnete.
Lebitso la ntate kana ke mang?
Ke kopa tshwarelo ke Daniel Nyati from Odd 1 Badirili Clinic. Odd 1 Bad Clinic. Ke ntate Nyati, yes ke yena. Ntate ke a tseba hore e kare ha re tsamaye kereke ele yengwe. Ke bua ka tumelo kana. ka religion a re ba bangwe empa go bohlokwa nako engwe re mo mmeme Ramasedi ha re kena mo dilong tse di tshwana le tseng ke ene a tshwereng senotlolo o ka di etsa dintho di etsa empa nako ya gage ha e so fihle gore o tswelle pele o keke ke batla re bue gape ka communication is power as the different stakeholders said the lieutenant government they must make sure gore le khona go kopana le bua into elengwe ka mo go hana ke utlweletse ka teng nna ne ke sogile ke re ba batla go contract ditaba ka wana ba semola yano ba questiona the presentation e le ka fana yano ne ke semola go nna dom yano iska ba ya etsagala into no gape ka bana nna ke tlo nna dom go feta wena ha ke ya ka kwa ha se ko bua yana aba ilukise into yeno no chairperson le tswalo akite kataba ya the presentation no I'm applaud you all as a Department of Health and legislation also because horare ka mansamangwe le riemetse ka kwana le gona go bona mathata a re na le ona imba taba ke gore le tla le ona ka mathata a simula mofatsa kodimo le gore ha ho yesa a document e tla be e itse gore dintho tsene re tlota ka tsona ke se re fediseng ka tsona jwale di sa go ke di recommendations and are sorry se re tlotlang ka fa are really to will cover in this small booklet that we received today. That is my question. In terms of tabaya termination of pregnancy, inana kungina lisoho like mare mushome kalwa keni ki choice relocise re ka ilokisa ka tsele yengwe gore motho a terminator a ne motho o re tseba gore a motho o repile a ne motho o repile mara motho from the blue to say I want to terminate into that is a sin, big sin. No le ntshwarele ke bua maikutlo aka ya ka botho ke a tswa fo ke ken a tlhokafala yene le ngwana rona ha re itse mathata a etsang gore ngwana le mme ba tsamaye lona le di doctor le di nurse ke lona le tsebang le bakala into e tshwantse re le tlakana re tlo re bolella re ha re tsamaya re a go gae re fitle re ba bolelle gore ala tshwanela go etsa tsena ala tshwanela go etsa tsena ka lebakeng la gore o tla re ha o fitla ko o thola gore wena entengwe gape ke ena ndate o lekile go nkgafaranyana mo dilong tse di ambulance because nako tse di go le ga nna le ba bangwe ba le ba tsamaya ke ba shebile ngwana ke wa ba fitla sepetlele ba re o tsamaile le ngwana ne re emetse ambulance di hour le di hour ya tla ambulance ka nako ya yona a batho ba ba berekang ko di ambulance ka kwa ba ko di Centenary ba itlhaloganye gore a ba fale ka bona ba fale ka lebakele nna ke teng ke batla go kena mo tabeng tsa bone bolwetse bo nakong o bo re fetsang ntate Letswalo ke chronic ya HIV and AIDS. Gona le ntho e etsang hore number yeli e tlhatlhogo ye ko hodimo. Gona le ntho e ba e bitsang bojala. Ka lebakeng ke a lwala ke chronic ke nwa bojala. Ha ke le chronic ke nwa bojala from Monday to Monday, from 1 to 30 December, ke problem. Inke ka gona go fola. Malwetse le bolwetse bo tlo nkgatalisa ene be ke fela. No, ne re kopa hore intensification ya di awareness ine yona of ki into e re ka etsang tota gore o rona re ka nna ke le chronic. No, ki rutiwe hore ha ke etsa inteng e ke o costa inteng ki live ki dule ki itse ki samaya ke tsoro ki nna ki ipolaile ha ona ipolaile ka ba nna ki feel intiate ya hore in sereletsa. Gona le intia rotation mama o buile fa le doctor fan ana ka tsa presentation taba ya hore motho o na le kitso ya mosebetsi o itse mo department of health, but we are removing that particular person to another area, and go fitela hore we need to get other person pili ka into ha fitla nna ke itse ke tshwanetse pili ke gone hore ke ithute into ke gone hore ke itse hore e tsamaya ba etsa into di etswang ke rona di councilor ha re kene ka fala a re nane ke le 5 years ke gona ke kenang ke tshwanetse go utla pelo gore na ba tsamaya ko kae. Thank you.
Aren't really that thing at serious can savolo go go fela. I get rumelane ka 3 minutes. Are tse number 5 ya rona. Ba holo ke kopara le bua ke re ke le kopile hore. Are focusing on the subject. I get.
Number 5.
Because are ka tsena go di kgantse ding. Ro kra ile hore ra latlhega. So ke batlo ikeletsa boikopelo bo tswetswe. Let's take number 5.
Number 5.
Kia le dumedisha kaofela
Mama
batho.
is number 6.
Number 6.
She was number 6. So who's number 5? Who's really number 5? Because we are now going to confuse numbers. So Mama is no longer interested. No?
Kaofela ka lebitso le le matla la Kgoši Jesu Kriste wa Nazareta. Ke Melina Mthapo from Ward 30. Ke a leboga. Ke a leboga. Ela go fumana sebaka se. Ke utlwile ka Maternal. Ke utlwile ka di course, ka kwa ka di solution, ka kwa ka di health education. Tsa teng gore from ning until ning le gore ntwena e nnile worsening because of COVID. E nnile worse ratio ya teng. So for hypertension ke utlwile ba re risk ya gona e ba gore mme a ka tlhokofala le ngwana a tlhokofala. So le nna ke ba e bona so nna ntho e nkemišitšeng haholo nka sie le taba tse ngata ka gore ka le magato a Department of Health a tšeang gore go be le solution ka di patient tse di le moo le di primary healthcare di teng for go solve the situation. So no ntho e nkemišitšeng risk ya di pregnancy mothers for the time labor. le ngwana wa tlhokofala. So go na le e nngwe ke mme wa but ngwana a survivor. Ngwana o survivor e le disabled. So ne ke kopa hore na how about solution ya tlhokofetse ngwana ena wa sala o ba teng problem ke disabled. So ne ke botsa hore na ha gone solution for gore ge mme a tlhokofala for hypertension e go be le solution ya gore ngwano is ka ba disabled. Ke a leboga.
Ke disability e tshwanang ala le fe mama.
Ke ngwana o kry le reng o no developer ntse a sa tsamaye a sa bue if ke ngwanana o ba reacha le status sela sa menstruation ntse le guga bia guga robadisha jisha a bue a tsamaye.
Okay. Let's go to
point e nngwe gape. Point ke gore re ne re kopa hore lena ba health for mona ditleliniking tsa rona ntho ena nke e qhobeke ena ya after ba rapela ba ya go thoma mosebetsi ya bona for the patient tse di tletseng mo nke re thole health education ka gore e tlo ba e re thusa le gore ntho ena gore ke dilo tsa batho e fela a ke re tla ba ba utlwile health education gore na what is the cause, what is the solution. Re ka isa re ke dilo tsa batho.
Okay, let's take number 7.
Phambili ngeGauteng asibe healthy GGT 2030 phambili.
Phambili.
Azo. Colleagues, comrades, I thank you for the opportunity. I'm going to be brief. First of all, I wanted to start off with a recommendation. Yeah, ambulance service being speedy or delivering the patient speedy from a primary health care facility to a nearby hospital. Obviously, I think our recommendation will run concurrently with the ESMO training, even in the ambulance services. That's number one. Number two, the trained staff on duty must always, on the facility now, must always be, they must not be short. We have come across issues whereby in our facility, Beggersdal West Clinic, you find that we are always short-staffed. However, you find that staff is not enough. When you ask around questions, you can see people are not wanting to tell you why they are short. But you can tell it's the budget thing again. So, especially towards this subject, it's a melanangli mo. I think it's quite a fragile issue. And number three, I'll go to number three quickly. Proper salaries or remuneration of staff is one of the core things. Because they are trained, these poor nurses, they work themselves to death. I'm not a nurse, I'm only a chairperson ya committee. I see, I hear, I'm just about every day go facilitating yak. So it's what I've realized, and you can tell by looking at the nurses on the faces, these people, poor people are overworked. If you can, I recommend that you try and get the budget thing in order, because it could cause the stress on them, their performance becomes minimal, you know. I still want to go to number 4. During antenatal care, pregnant women across the age line must be discouraged or educated not to drink the homemade concoctions during pregnancy. Could be one of the things that causes some of those things. And I'm sure that education has been running forever. The issue of all the medical staff, your ambulance services, they also need the emergency and at MO level. They all must go for debriefing, because these people Because just about every day in my facility, I see things, I hear things. I'm even afraid to go there now. Because le nna ke tlo need a debriefing.
So, la utlwa bo mme ko morago gore ba re le se ka rwa dirapa. Although na le tsa nnete, mara tse tsa ka jeko tse, a re di tshepe sentle akere.
Number 7.
So re kopa gore- alright.
Seleke. Ke tswa ko Mohlakeng healthcare bua ka di soft borders. Gora gore now our nurses or our healthcare at the provincial or I am checking gore in such terms our nurses understand that they are understaffed or here away. But now in terms of our measures do we have in place go avoid gore ba be overworked. E le gore wa ba bona gore they are just trying but ba kgathetse. How do we deal with that? Facility managers gore we should recommend to the MEC maybe kana kong ba need gore ba shift work from this vicinity to another one. Ka tsela e leng gore le bona ha ba tla mosebetsing ba tla ba le mafolofolo because ha ke sheba ko Mohlakeng committee I was heartbroken ke utlwa there now some other tools of work any and then it went ko legatong for reparal and then those issues if there's those tools of work they are contributor mo eleng gore na o kry-ile gore mathata a etsagala within the nursing facilities so because of lack of tools of trade ba ikry e le gore na afford go etsa mosebetsi better because it was even worse about it they had to in terms of the budget high itla let us refer the proper tools to the nursing staff to the clinic that mesebetsi e kgone etsagala ka pele in terms ya go avoid all these issues tse re sa batleng go bua ka tsone like today I submit.
Okay, thank you very much. Let's take number 9.
Our speakers protocol observed.
Number 9.
Number 9. Number 8 to read.
Were you number 9?
Go to number 8. What's this?
You were number 8. It's okay. I can skip number 5. Let's make you number. You can speak, ma'am.
Oh, I can speak. Good afternoon, everybody. I'm not representing any.
If you can just hold the mic closer.
I'm not representing any group or just an invited person, and I feel that I must say something. My name is Sophie Mohotane. I'm a nurse, but I'm a retired nurse.
You don't want to use that designation.
No.
Prof.
No. Okay, I'm Prof. Mohotane. I think that the department is doing a lot. But from my nursing cap, I find that what the doctor presented was mainly a medical. The mother who is delivering in the hospital or at the gate of the hospital so that she can. From my side, I think the problem can be addressed from the basics. I think patients at risk coming to the hospital. I actually took my speech, you know. I just want to talk about, we have got the 3 categories and the R169 and the R171, which are the 1 year and Midwives are only produced in the R174, which is in the universities. So when we cannot produce adequate numbers of midwives, the colleges do not take more than 70. And that 70, it doesn't mean that they will, but removing these qualified midwives from practice into skill that's left is the basic skill, and there is no mentor there to mentor the new midwives, whereupon we should, as the presentation showed, complications can be identified early. Be person who is being treated, who is being now followed up. It won't be not been attending clinic or attended clinic late, and we do not know much about her. With that, I really want to recommend that let's focus our attention to the districts, to the clinics, and make sure get to the end of their pregnancy well, and we don't crowd the hospitals with complicated issues. Thank you.
Thank you very much, Prof. I know I was out of a step because I had to reveal. I really had to make that revelation. Or, amongst us, you have got sagacious minds on this specific subject. Let's revert back to number 9. Sure.
Dumelang bagolo, our chair and all key speakers, protocol observed. O emi mona ke ritumetse Morokane. I am a field Morokane. Yes. I am from Rotanganetsa Community Care based in Brandflay. I am a field researcher for the community-led monitoring program. My point is on IUCDs. Dr. Ubile, the report yako district, there is a shortage ya IUCD. So my question, like more that report, is the shortage the actual product ya IUCD, or is it the training of the staff? Because from my understanding as a field researcher based in Talton, a staff se khona go give the service ya IUCD. But in terms of the product itself, they can only provide the product if there is a nurse only trained. So ke batla go tlhaloganya gore, is the issue the product itself or training ya the nurse? Yeah, that's for me. I submit.
All right. Thank you very much, Ma'am Rogan. Let's take number 10.
Dumelang bagolo, protocol observed. Lebitso la ka ke Bishop Lubeko, ke mo mokgatlong wa MCMC, o bitswang Orte Mogale City Ministers Convention. Re reporter under the speaker wa Mogale City. Chair, ke tlo bua ka experience ya me. Once 2 years back, I gave birth to a daughter. Then on the clinic side, they said kinale high blood. Then I drink the pills until I became pregnant. To my surprise, when I get to Leratong, because I can't get more risky. When I get to Leratong, they do the medical test. I don't have something that they said I had. Sorry? Yes, I had it. To my surprise, this is my 4th child. When I went there, they said, when they test me, they said there's nothing wrong with me, I don't have. Which day, because it took me 11 months for me to give birth. Then the criteria when I get there, because I'm over 40, and then when you are over 40, it means that there can be a risk of anything, anytime. But what I experienced that chair, when I got to Leratong Hospital, ke ratile mama on thathuse pelo, like seriously. E bontsha bagolo ba pepang. They will drink tea. Mogolo o tla go. You will know him like, no, you don't understand. Live like that, the child will come. And immediately 2 minutes, the child watswa, mme ha go one already diseased. Because there's no care there. And then when they try to obote, they will shout amongst you to say, no, I'm a professional, you are not. So that's why mama ke moratile, because of if go ka ba the qualified people that knows how to go pepisa bomme, I think they won't be on this rate that we are living in. Secondly, my chair, as Baruti, we are part of the counseling team. Only medical part only. It despair people or the mothers that is left without a child, or the child that is left without a mother. One way to the road, those people, they're coming back to the churches to say they've got the distress again. We need to cancel them as pastors. Because a cooperation between the Ronale Health Department. If how can between pastors and government, it's gonna be easy for them, because when you cancel them physically, we cancel them spiritually. So if it might help reducing this part, because history is keep on repeating itself. I thank you.
Because clinic committee ke moshomo wa yona o. So you are acting as a liaison between different community-based organizations. You know, you are bridging the gap. So tshwanetse le kgone ho organize. Bomme Bishop Mbeko le ba tlise ntlosa to our facilities, including our hospital boards. I know the department has advertised now for hospital boards. Those that are going to be appointed must understand their role, you see, to bring community organizations at close. Let's take number 11.
Dumelang bagolo, ka leina ke Lerato Modukanele, ke tswa ke le ko Semonye Clinic in the West Rand. I think most of the points that I wanted to make, di setse di builwe, but
O ile ka speed ke mme mang?
Lerato Modukanele.
Mogale.
Modukanele, MODU.
Modu.
Okay, the first point that I wanted to get clarity on ke taba ya di discharge form. Ke utlwile our director a bua ka taba ya discharge form gore there's a form that is filled before you get discharged. So ne ke batla go itse gore that form, is it only utilized in hospitals or is it also done ko di MOUs? The reason I'm asking that is I'm talking from experience gore in the pregnancies that I've had, say two, I was informed that in 6 hours time I would need to leave the clinic. I was not even aware what was the reason, like do they properly check me gore ke right before ke tlogela ke tswa ko clinicing, only to find later gore ke bile ka ba le challenge after they removed me from the clinic. So ne ke ka rata go itse gore what is the turnaround time ya motho o fetsang go pepa a tswa ko MOU. And then antenatal education as well, bagolo. I'm not sure about other clinics, but from the clinics that I've observed, antenatal education is no longer done as it was done long ago. We get to clinics whereby wakena okra treatment ta gago dipilisi tseo, and then you are not educated as to what are the risks of pregnancy, how yetsa sona go tlo etsagalang, how sa etse sona go tlo etsagalang, and whether you are high risk or not. Intlisa mo tabeng ya transportation gore ha o founela ambulance at some time. I think the other challenge increasing the mortality rate ya bo mama. It's because of that. O ka founela ambulance and then they will ask you whether you are high risk or not. At that time, you are not even aware of high risk or what. Those are the things that are not communicated with you prior. How to make the antenatal classes. And then ambulance shortages. I think that the Mazibuko touched. We need to have the ambulance shortages, the ambulance more in our areas, so that hospital delay. Because sometimes it might happen that delay cause ambulance 6 hours so go fitla ko mothong. only to find home to oh wa deliver and then there's complications there wa tlhokafala kgotsa ngwana wa tlhokafala. So I think that also needs to be taken into consideration very strongly so that re ska nna le mathata a tshwanang le yalo in the future. Thank you.
Thank you very much, Nne. And then let's take the last hand, number 12. Negrilatle mo pele akere ke mang? Oh, ke ntate Moruti. Oh.
Thank you, Chair. Greetings, Chair, Honorable Letswalo, and your committee and everybody else, all protocol observed. I want to first say thank you for the beautiful presentation, Director. I'm just going to speak on the few things that I picked up on my side. The first thing is your Reverend Zex Charlie from Rand West FPO and West Rand PPCSA. 2 caps today. The first thing I want to comment on my leadership is your CTOP facilities. I'm saying thank you for increasing them. Like you said, from 41 to 42 or 45 for the first semester, from 9 to 12 for the second trimesters, I mean. But my question is, I know it's probably beyond the scope. In comparison of the illegal ones which are found on every corner in South Africa, what is the contrast there? If it's outside the scope, are you liaising with those responsible to say what is the clamp down ratio on those? All right. And then you also mentioned, Director, the health soft borders. And I may have been wrong in understanding it because I assumed you mean the neighboring provinces. But now, my question would be, what about those not necessarily neighboring? For example, I'm from Transkei, Mkankato, Kokombo, and then you are here now, and then are you able to be integrated within the soft border protocol? And then you gave us numbers, and they say, Honorable Chair, numbers never lie. You gave us deaths 22 and 23. It said 341, 266, and 217. I would have loved to know more meat on those stats. For example, out of how many that came in, out of that number of mortalities that came out, what is the age group? Where the youth were from? I think another comment did say foreign nationals and the staff. And then against the guidelines or the targets, I understand that WHO probably has given you guidelines in terms of how many, what is the ratio there? I would have loved to hear more information on that. And then the other thing is, I think Umama touched on it when you said we are talking inpatient. What about those? Because childbirth happens everywhere in South Africa. It happens in a taxi, it happens on the road, it happens at home. In January, we had a very close call. It only happened when one of my church members called her mama from work that she's not feeling well. On their way home, she gave birth. She was not aware that she was pregnant. So, what about those? The mother survived, but unfortunately, they lost the child. And then the other thing you mentioned is your OMPUs. It's a good intervention. I love that. My only question around those is, what about at the place where the people are? I think everybody's been talking about your PHC centers, the clinics, because as long as the services are only in hospitals, you'll always face overcrowding. What about these midwives? What's that training? ESMOs, in the people in those levels, where the people are actually happening. And I think the leader said, that's even advised that, what about the people in the ambulance, your emergency personnel who are on site first before everyone else? And then lastly on my side, I noted your expert group for recommendations to improve early pregnancy detection, I believe, and complications. Now, I'd love to know to how far does it go? What about the people? Are people being educated? Is a part of their scope? What about the children at school? Are they being educated on these things? Because I'm thinking now, even with the situation we had at church, if someone for 6 months didn't go on periods until they give birth, how did they not assume that they're being pregnant? I'm going to leave it there for now. Thank you.
Thank you very much, Bishop. I'm a reverend. I don't know the difference between bishop or reverend. Mind us to open with a prayer.
We're not here.
But we can close with a prayer. So that whatever that we're going to resolve can be ordained. Again. Yeah, so prepare yourselves. Prepare yourself. You know, I would have wanted to hear, I see here amongst the stakeholders that we invited, TUT Tshwane, are they here? You are confirmed, but we don't know if you are here. SG Lawrence, are you here? Who's representing SG Lawrence? Then you'll be number 1. Rahima Musa, campus, you are going to be number 2. Esefako Magato, as I write reports to all of them, right? You'll be. And the one of SG Lawrence, is shopping around the town. If they are not here, I get it. And then, which other one is here? Dinosa spoke. Is there anybody from Life Health group? Life Health. You are confirmed here. Says we have got somebody from Life Health group. You know, maybe we must get the actual register. Yeah, you are going to be number 4. Or is it 3? Number 4. Because we also want to hear. Are you fine? Mama, Prof spoke about are we producing the right kind of midwifery nurses? Record all the challenges that there are, and then I'm not so sure if I think those are all the. I can't see if it's ANV. No, here Latsky. And Latsky. Yeah, so you're going to be number 5. So there's 2 of you there, or 3, or 4. Or 5, 4. And then, Mama, when I come around, representing, you want to go, let's all on LML. Mama, what the braille? Oh, and Lensky. Okay, so we're going to have how many? 5. So let's hear from you. We've given you those are numbers. As training platforms. What are the issues? 1.
Honourable Chair, thank you for the opportunity to speak. All protocol observed. As from our side, I think we are looking for a bigger participation between public sector and private sector. I think the private sector should be more involved and specifically also more with training. We have, and we are looking forward to that. We have a good relationship between Arba Medical Center and the Training Institute. One of our concerns is midwifery. the numbers are reduced and we are running into problems. So I think specifically with the private higher education institutions that we should also embark on providing midwifery training in future. And I'm looking forward to that. Thank you. Our numbers of intakes, we do not take midwifery students in, and SANC prescribes the number of students, so we have small numbers of 169 and 171. I think we've got more than other private health, higher education institutions, but our numbers are limited.
Big number.
Can I just introduce myself? I didn't introduce myself. My apologies. My name is Dr. Annelies de Villiers.
My name is Pesina Mantime Molekwa. I am the campus head for Rahima Musa, one of the campuses of Gauteng College of Nursing.
Mema?
Pesina Mantime Molekwa.
Oh, Mema Molekwa.
Era. I just want to take this opportunity to thank the chairperson for to be representing the institution in which I come, and also take this opportunity to say all protocol. Mine would be from the speakers that have spoken. I just want to talk about the resources. I acknowledge that there is a challenge with regards to specialist nurses, especially in the maternity section, which might be one of the contributory factors for us to be sitting with high maternal and infant mortality rates. And I do acknowledge from practical point of view that when I visited some of the institutions, whether it's private or public, I happen to see that people who are manning certain departments like the various maternity sections are people with less experience by virtue of their qualification as displayed by what they are putting on their uniform. Now this becomes a concern, and if we can all remember, training of specialist nurses has been a challenge when the transformation came into effect. There was a shift from legacy programs to the new qualifications which are pegged on the national. Now this delayed the process for us to produce specialist nurses until 2024, January 22nd, when Rahima Musa, which is one of the campuses of Gauteng College of Nursing, as well as...
Number 3.
Good morning or good afternoon, everybody. My name is Khomotso Mabasa. I'm a midwifery lecturer at Sefako Makhato Health Science University, but currently I'm now teaching the postgraduate diploma in midwifery, our first cohort. I have identified a lot from these students. During the course of this week, I was actually listening to the presentation made by the doctor that side with regards to an increase in maternal mortality. Having to find out from my students what they knew about maternal mortality, most midwives knew nothing even about the Saving Mothers report. As I'm speaking currently, I'm saying I'm teaching those that are having a green bar. But when I was trying to find out from them again about what do they know about ESMO, midwives knew nothing. So I tried to beg to differ, especially from the presentation that was made by the doctor, not to say that I'm criticizing you. I'm only saying that from that side where I am, ESMOs are not being conducted as it was indicated before. Then number 2, I have been lecturing the very same R212 postgraduate diploma in midwifery at Garangua campus, when I go for clinical accompaniment to check for the students at the present moment where I am, most midwives that are being trained, they are gone. What is the problem? The problem is with retention of personnel. I so wish that the Department of Health can take it into consideration that midwives as independent practitioners and midwife specialists are so scarce. And secondly, they are being poached by the Saudi Arabians and other developed countries because they are happy about the current education that is being given in our country. Number two, we are short of clinical facilities for placement of students. Why? Because the issue of the cross borders, we are very much close to the Northwest Province, where there are so many clinical facilities where we can place our students. But because of that, we are unable to have that intake that we desire, because we cannot overcrowd Dr. Josh Mukari, or we cannot even overcrowd Steve Biko. And to crown it all, we are also placing at the district hospitals, whereby the risk factors are very much limited. Therefore, overcrowding at Dr. Josh Mukari or Steve Biko. Therefore, I'm pleading with the Department of Health to allow even the cross-border or cross-provinces clinical placement so that we can have or we can increase our intakes. Thank you.
Thank you very much, Member Mabaza. Points well recorded. Let's take the fourth speaker. Oloago SJ Lawrence ke S Mogotlan. Okay, Mogotlan. Oh, I will again. No, bro, will. What S Lawrence? Okay, it's okay. Yeah.
Okay, good day, colleagues and community at large. All protocol observed. Thank you for the opportunity to talk on behalf of the training institutions. We appreciate the opportunity. From my side, I'm Takani Sitole. I'm an HOD for midwifery, advanced diploma in midwifery at Chris Hani Baragwanath campus. We are training
Why is there maybe voice in here?
I'm Takani Sitole, academic HOD for midwifery at Chris Hani Baragwanath campus. We are training the basic program of midwifery before they go to Rahima for advanced, for the postgraduate midwifery. In our training, I just want to share that we do incorporate the recommendations that were tabled earlier. Our students are made aware of all the issues that are highlighted causing the maternal death. And they are even also given an opportunity to do the ESMOWE training. We just want to extend the request to Department of Health to support us, because we do want to also be given an opportunity as training institution to be supported by training our staff, including the various students, so that we know when they are qualified, they know exactly the correct thing that they need to do when they are in contact with the patients. And then the other item, we also appreciate the presentation that was made, and it has highlighted some of the services that were increased in the community, so that we try to keep the areas of concern. From my side also, I would like to say to the communities, we appreciate the gaps that are identified amongst us as the midwives, even at training or maybe even at clinical area. But we are also pleading to the community to also work hand in hand with the midwives. When they are advised, they should follow the rules. And one thing that was mentioned was about drinking some herbs and other things that are contradictory and which may cause some of the complications to the very neonate. We know, like we said, we are blacks, we normally have some remedies that we drink. You'll be told they will help you, everything will be well. Or when you are about to deliver, you'll be given the Islam bezo to say your delivery should go well. But all those medications are actually causing harm to both the mother and the baby, more so on the baby worse. It's a worse complications that are occurring. So may you please also listen from your side when you are advised. On the issue of health education, I'm not sure what went wrong, but I know when the students are trained, they are taught all those things and everything is explained that it is important to teach so that we prevent the complications rather than sitting with treating the complications that has occurred because we failed to share the information with our clients. And then my other request is from the side of the community to say, we have realized that we are placing our students at the MOUs. But unfortunately, when you look at the stats, we are accredited there, but the students are, the patients are not there. They are going straight to the hospital. We wonder why. So maybe even from the health department, we can request that we need to embark on making and strategizing and making sure that maybe we try to assist the MOUs, maybe to benchmark themselves in the communities so that they are utilized. Because the communities or the patients, they pass the MOU that is in their own vicinity, 5 minutes away or 10 minutes away, they go to a hospital as far as 20 km away. So if that area can be attended to, maybe there will be improvement because they are also denying our students an opportunity to also have the deliveries or learn more at a more relaxed environment because when they start, we think the MOU will be more suitable for them and then as they progress, they then go to the hospital. And then the other issue is just to also extend the request from our colleagues also in clinical area to also support our students because we are all trained and we are supported to become who we are today. So it's only with our support for the students that we can make a difference and make sure that they leave the colleges or training institution well learned and secured with what they have learned. And then the last one is also that to request that maybe the very midwives, it was also highlighted that they need to be supported psychologically because in most area we also find that there's a shortage of midwives in the either hospital or even in the MOU. So if they can be supported, we think it will assist them. Thank you.
Thank you very much, Members Toll. And then I think we're the fifth person, isn't it? Yeah. We are going to conclude with Enlads. Yeah, so after okay, I think that's it.
Good afternoon, everyone, and thank you very much, Chair, for the opportunity. I just would like to focus on the issue of training that was raised earlier in relation to the production of midwives. I am Lindiwe Mohwaduba, the campus head at Enlatsky campus of the Gauteng College of Nursing. In the meeting, who is the vice principal of no, it's not me. I am Lindiwe Mohwaduba. Lindiwe Mohwaduba from Enlatsky campus. My area had been phasing out. So the last cohort of midwives came from end date was 2019. So there was a teaching out period, but the last cohort to develop the new programs, but 2024, the advanced diploma in midwifery cohort started. The cohort was really a teach out period. But in 2024, 200 midwives, that program is running. So I just would like to also highlight that university degree that produces midwives, but there is a level in the campuses of previous year, 2024, 200 midwives came into the program. And in the 2020, in the previous week, I also just highlight that the extension in those numbers is on application with the South African Nursing Council. The last thing I just would like to highlight is the fact that programs, the midwives are even assessed before they on the SMOEs. We also would like to appreciate the fact that from TED in the teaching and learning for the students in the college, and we work hand in hand with our clinical partners.
Professional stakeholders, isn't it? And of course, they're also quite crucial in a way, the platforms. And if there are deficiencies there, you know, so we really want to appreciate that you could unravel all of these points. I think the take home for me is adequacy of a training. You can't take shortcuts. So it's a discussion that we need to reflect on. Of course, when time of the old cost construct as against what we currently have, and whether there has been to draw a contrast around what used to work back then as against what is, you know, because you can't allow fluidity in respect of the output on training. Otherwise, it undermines the ability of the system to respond with the right kind of a skilled or informed decision making, you know. But I suppose we have recorded some of the points that we will have surfaced. Allow me at this stage, having heard from all the stakeholders, my director, to respond. We are now responding. Again, some other things are contributions, how they could potentially work to strengthen the health system. And you know, we are standing at the cusp of a new dispensation, unbeknownst to any one of us, which professes itself to modernize, but to heighten access to healthcare services, which is the NHI. But with the NHI, you really need to ready yourself to make sure that contradictions, entanglements that are currently plaguing the system are resolved. Otherwise, it might be futile to migrate from what we currently have and say, let's maximize access. Only that access is not followed by qualitative inputs. You know, so I really think at the back of our minds, how we reason, you know, some of these programmatic interventions, we need to bear with the eminent reality of this new dispensation. You know, otherwise, yeah, it's the inverse of what we are trying to achieve, honestly speaking. You know, but allow me, Director, to hand over to you, and then you would lead us. Should you feel any need to raise any one of your peer managers, I think do that, so that they can help out as well. Bo metselanyana ba teng, a ko ba bue le bona.
Okay, thank you once again for the opportunity. I hope I'm audible. Yeah. Okay, as said, some of the inputs that were given were, okay, comments. So we'll look at the questions that were asked. I will try to respond to them, and then my seniors there, if there's anything that I have left out, will come up and assist in answering. Okay, the first question was looking at the presentation, that they don't know sort of what is it that we are presenting. So we were presenting, looking at the request that was sent out, that we need to look at the triennial report, which is from 2017 up to 2022, regarding the maternal deaths and what is the Gauteng Department of Health doing in connection with those recommendations that were said or that were put forth in that triennial report. In those two triennial reports, as I indicated, that the triennial report are done 3 yearly. Yeah, so some were saying, why did we not give the statistics? The statistics are old, is because we were responding to the triennial report of 2017 up to 2022. But anyway, let me help you if you need the stats. For example, my presentation ended with the maternal death up to 2023. So for the financial year, and that was the calendar year, and then for the financial year of 2023-2024, we are having 223 maternal deaths. In my report, as I indicated, it was the calendar reporting. So the financial year reporting is from April up to March. So from April 2023 to March 2024, there were 223 maternal deaths. And then for this current financial year, the maternal deaths from April up to December, they are 188. So we will look at the end of the financial year as to how far we are with those. Okay, and then there was a question about how many women went to the Ombus. Remember in the presentation I said we are still looking at that implementation of the Ombus, and currently all the women who are delivering, who come to our hospitals to deliver, they are recorded there, and also in our pregnancy, that is there any reduction with teenage pregnancies? Two, we remember it was on the media, and a lot of teenage deliveries. And by the way, for us to get the number in our institutions and the termination of pregnancies, the 45, and then they went a bit up. In 2022, 2023, they went up with about 496. But when we come to the year 2023, 2024, those went down with 954, meaning that in 2023-24, we had 23,987 teenage pregnancies. And then the current financial year, when we compare the 2023-2024 statistics up to this current financial year, up to December, we are having 17,428, but we know statistics keep on going up and down, and we'll see in this last quarter where they are taking us to. But when we compare, we see a reduction of 6,559 teenage pregnancies, which shows a great improvement. And when compared, okay, no, let me leave that one. I think I've answered the 1-year teenage pregnancy. And then, okay, there was a repetition again, the triennial report. I've responded to that one. And then there was also a concern that the report that we presented on IUCD, intrauterine contraceptive devices, is not a true report. And they compared it with the Q3 report of this financial year, or with the report of this financial year. So as I responded earlier, those recommendations, we were looking at recommendations for the triennial report 2027 up to 2022. By then, we were not having those shortages. But in the coming report then, that's what we will be able to report on. But on that one, the facilities that reported shortages of IUCD, we requested them to look at their stock, at their stocks, so that they avoid having stock outs, or they were encouraged to order stock on time to avoid, these shortages. And then tracking of sick babies. There was a question that, is the department tracking sick babies? Okay, the department, we are having the word-based outreach teams that are visiting our communities or homes, and they link the services that we are providing to our communities with the primary healthcare services. So as they visit the communities, they also look at the health of children, including the Road to Health booklets. And if they identify that these children did not receive any immunizations, then they refer them to the nearest facility. Not only that, we also look at the growth monitoring of the children, or any other health problem that they identify. These children, they are referred back to the facilities. And then those deaths that are happening in the communities, they are reported at Home Affairs, unless if it is a death that comes to hospital, and then that death ends up being a DOA, death on arrival. Okay, so those will be seen at the hospital. So, but all the deaths that we are reporting on, they are those that are reported on the district health information system. Okay, issue of shortage of midwives, I think that was a comment, especially from our colleague from Dinosa. Those were comments. And then also the issue of Rahima Musa, that is having shortage of staff and women that are found to be lying on the floor. I think those are problems that we'll have to look at, and thanks for raising those up, because when such things are raised up, management are expected to look at those problems and attend to them. Okay, and then there was a point on overcrowding, and the advice that we need to have interns at MOUs also that will assist the midwives with this overcrowding. We'll take that forward, and see how this can be dealt with. But in MOUs, sometimes we are dealing with quite a low number of women. That's why maybe we are having midwives delivering there. And then if you can remember in my presentation, I identify that those women who are at high risk, or who are identified as having high risk, we ensure that such women always deliver in hospitals. And then maybe to link it with one comment from our colleague, or one of us, who mentioned that she was not told as to whether she's a high risk or not high risk. At times, okay, you can be told that you are having hypertension, but they won't say you are a high risk. Or they will tell you about the health problem that you are having, and that problem will be addressed or managed, for example, anemia or whatever. We won't say, hey, you are a high risk. Maybe between us as health workers, that's how we will talk about it. And then the issue of foreign nationals, there was a question to say, do we have numbers of foreign nationals that are visiting our facilities? We have actually tried to track that issue of foreign nationals, we requested some numbers from various hospitals and MOUs. We were looking at foreign nationals who delivered in our institutions. And when we look at the stats that we are having, it was found that, okay, in 2019, we had about 8,984 foreign nationals delivering here. 2020, it was 9,619, and then jumping over to 2023, 2024, when we count all of them, even those that I've mentioned, it was 39,230. And this, we are talking about those from Zimbabwe, any other place outside South Africa. Ne? And then my seniors will also correct or input on that one. And then currently in Q1, 2024-2025, we had 9,271. To link this, there was a comment that asked that if I'm from Transkei, am I counted as a foreign national? But according to my knowledge, you are not a foreign national because you are from South Africa. Okay. All right, and then, okay, there were comments that there is a need to debrief our midwives, and we are looking at that. But according to my knowledge, I know that districts do conduct or do have some trips or debriefing workshops that they are doing for their staff. We just need to strengthen that then, if it is still not enough. Okay. And then there was also an issue of ambulance delays, though in the presentation we presented that there's some additional ambulances that were procured, and my seniors are here to also look at the fact that there isn't going to be further delays. And then, yeah, the issue of soft borders, we were talking about areas like Kotswani, where we are having Northwest next to Tshwane, Malanga, just cross a street to come to Gauteng. So that's why we are having that committees and are not from South Africa or are not from, not keep on returning them. And then are utilized, as mentioned, that this is according to the maternity guidelines. So we are also utilizing. Okay. Akere, in our MOUs, we do not keep patients or mothers or clients for long, like in the hospitals. In the hospitals, they might stay long because they might be complications, But in the MOUs, they usually stay for, is it 6 hours? Yeah, 6 hours, and depending on the condition of a woman. Because if it's after, okay, during that 6 hours, that woman will be monitored. And then if she deserves to be referred to a higher level, to a hospital of a higher level, she will be referred. But if the condition deems that she be discharged, then she will be discharged after all the things are checked according to the discharge form. All right. The ESMO we've spoken about. Oh, there was a question that said, are our children in schools educated when we are looking at issues of teenage pregnancy? I get those tests that I have mentioned. So in Gauteng, we are having teams of integrated school health nurses that are visiting our schools. They visit in order to screen learners and with an aim of identifying any health problems that the child might have. If they identify any kind of health problem, then they refer him or her to the nearest health facility. If it is a girl who is reported to be pregnant, she will be advised to go to the nearest health facility. As mentioned earlier, we are encouraging that anyone who identifies that she is pregnant, even before 20 weeks. The 20 weeks that I spoke about is the indicator that we are reporting on. But we always encourage that if any girl, any woman identifies that she is pregnant, it can be 2 weeks pregnant or whenever, go to the health facility so that you can be examined, so that you can be checked to see if you don't have any health problems, so that they can be attended to and so that you can be given any advice. And then going back also to the school, our nurses work together or in collaboration with the educators in schools, and we know that in schools there is a curriculum that is conducted, and together with the life orientation, they will work together with them. If the educator requests our team to assist them in the curriculum, they will be providing the health education then. But the education curriculum focuses on body development, puberty, where they are taught also about menstruation, where they are taught also about pregnancy and the importance of sexual and reproductive health. Rights. And then with the department, as our teams are visiting our schools, we are encouraging them that they have to link them to the nearest health facility. We are linking the schools with the nearest health facility so that any learner who has a health problem should be referred to the nearest health facility. In the clinics, we are encouraging that we need to be implementing adolescent and youth-friendly services, which is a concept that has been taken, and the department is currently retraining our health workers on adolescent and youth-friendly services so that any young child or young girl who visits a facility should be treated in a friendly manner, because for sure you know that there has been instances where young people will be saying, I don't feel free to go to clinic A or clinic B. So by implementing adolescent and youth-friendly services and youth zones, we are encouraging access to our health facilities by those young people. Remember we spoke about the backstreet abortions? So we don't want to see our girls going there. That's why we encourage that come to our health facilities, because we encourage also the youth zones, and a youth zone is just having time, an hour or so with young people, educating them about health-related issues. They can be educated by a health promoter or any other health personnel. And with the youth or young people, the first thing that we do, we encourage them to abstain from sex up until at an earlier age. And those that are unable, we are saying they need to practice sexual practices, but abstinence, that's what we promote to our young girls and boys, because it takes two to tango. Ne? All right. There was a mother who said she was not treated well. Okay, I heard that when I was going out, but we apologize for that because we don't want to see anyone being treated badly in our health facilities. That is why our current MEC is also encouraging what we call serve with a smile, so that we improve access to our health facilities, and we don't need to be hearing all the complaints that are raised because of not being treated well. Issue here, ESMO, I think a lot was said about it, ESMO training on emergencies, and then our colleague from Dr. George Mukari, these trainings are happening, and maybe I will link you with Miss Rebecca Makau in Swani, just to give you more details. It might be those students that came for the training, some of them were not trained on it, but it does not mean that those trainings are actually not happening, because we do receive reports on that. And anyway, they are here, the district clinical specialist teams, they will also talk for themselves, so that it's not only me who's talking. And then, okay, also Bara, yes, they supported that they do also train and, on ESMO. And then, okay, they have indicated that the midwives will also need support when it comes to the ESMO trainings. And then they also stress the issue of providing psychosocial support to our midwives. That, yes, is really needed. I think those are the things that I have jotted down, and I will hand over through you, Chairperson, to our managers who would like to add anything that I have missed?
No go lebuile me mamzondi. Hey, lebuile man. Or you know, or you were paying attention. You responded adequately. But let's check. Are there any of the managers who might want to supplement? Maybe even elaborate on some other points. Is there anybody you want to comment? So you'll be okay. Let's allow a flow. Ne? Maybe let's hear what the gentleman before you come.
Protocol observed. Ke ithutile a lot about that. My concern ke moeletsi John Pajani, ke one of the committee members.
Requested people to raise their hands when they wanted to speak.
The question.
Several times.
Yes.
We have just responded. We can't go back. I don't know about lunch. I get. So, the question it would take us speed, then you will be the only one.
Thank you very much. It's just that some of the questions did color after hearing the responses to everything that was spoken about. Market like keep us short. And what fellow iti kataba yabana ba underage. For an example, telling one at 12 or 13 years we love for pregnant. Mola waits a young in terms of rolatelisis atabaya. Rape because one underage in South Africa iti gore if o robala lene ale underage it's a rape. So ne ke batla iti fela go ale pregnant aya go bodi petlele before deliver a tsang ale thola gore o underage go etsiwa yang go thole perpetrator e mo impregnating especially ale gore ke motho mo golo mo ngwaneng. That's all.
Ayo le nanga wara ke statutory rape again. And then clinic law enforcement, they report. Law enforcement, they investigate again. So, law enforcement, it's a very serious issue. I mean, we're seeing a prevalence of, teenager pregnancies. Some of them from relatives, even siblings, So, yeah, I think as and when that happens, the facility, the health facility would correspond with the nearest police station so that they record that case and it be investigated. Facility around how that case is being handled. So let me allow the managers to maybe quickly come in. Please don't be too long. What has been responded to, don't go back to it. You can elaborate here or there. If necessary. Thanks.
Thank you, Chair, and the leadership there in front, colleagues, and the community. I just want to thank Maros for the response, but also colleagues, we have noted all your, maybe let me start by introducing myself. I'm Refilo Mutsamai, I'm the Acting Chief Director for Health Programs at the Provincial Office. I just want to add on the issue that we acknowledge the comments and the recommendations that DENOSA, those were recommendations, definitely we will input in our responses, and to also reassure the colleagues that the Saving Mother report is there. We will share with the colleagues, especially those who have stated that they don't have. I want to touch on the issue of the faith-based organizations to say we have established the relationship led by the ABC and that as the convener of the faith-based organization. So while you are speaking, I have noticed that maybe we need to strengthen the local level relationship. So therefore that we will do, we promise that I know that Mayor Karigani have said there is there, but then it needs strengthening. So we will definitely do that. But on the issue of health education, I think that is a very important issue that we acknowledge, and we are saying we are going to make sure that we strengthen the health education because that is important. Everything else, it starts with the community. If we can prevent certain things at the community, we will not have our clinics and also the hospitals being burdened. But also the health education part, we do have the multimedia social medias, where we are sharing, especially in terms of the pregnancy, especially in terms of the mothers, to report early. So those are also the issues that we want to strengthen. I will pause there, colleagues. Thanks.
All right, who's next?
Good day, colleagues. All protocol observed. Thanks, Chair, for the opportunity. I just want to answer one question that was specific to Tarleton Clinic. We have the IUCD in stock, and we have the nurses who are trained trained on contraceptive and fertility planning. However, they need to book the patients, and because it's a choice of a patient, we cannot force patient to insert the IUCD. So that's where the challenges come. If the patients don't want to insert, we cannot force them. And she has to be mentored with patients that are booked. And the second one with ESMO, we are training ESMO. Currently, it's happening as we are speaking at Yusuf Dadu. And then on addition on health education, our health promotion is doing the best on that. Thank you. And Prof. Mokhatlane, by the way, I'm your product. Medunsa 2008. Thank you.
Okay. Anybody else?
Dumelang and good afternoon again. I just want to respond to the issue of increasing placement sites for students so that we can train more midwives. So I'm appealing to Prof of SMU. If we can engage and resuscitate, probably you can put a submission together to SANG to allow you to place in Northwest. Where there are barriers, let's hear what is it that are not making us, because we need to train more students. And on the issue of debriefment for staff, you've raised a very important issue. Denosa and the others, we would investigate what happens to those nurses that have been involved in serious adverse events. And with the same breath, we would want to look into the terms of reference for these M&Ms. What are the actual objectives? Are nurses well represented and they are given a voice to speak and actually advocate that necessary care is given to them? And the other one that we want to look at leadership is the reason why our nurses are leaving. It is important that we gather that report of the exit interviews and actually analyze. It's time that we actually develop, motivate, train our leaders to be people management, to be nice, to be kind to our nurses, because now we want to keep them, especially when they leave, there's no replacement, employments are not happening. I think as a leadership in central office, we need to look into how we retain our nurses.
I agree. I mean, one of the ways to incentivize the retention of health personnel is just improving their working conditions. We're not even talking monetary interventions, just the improving, the working platform. You will find that it will go a long way. A lot of nurses have got a mainstay of wanting to carry on, but their biggest lamentation is that I'm in this facility. We're short of this or that equipment. We don't have this or that. Non-clinical things. A nurse ends up having to be a porter. It sort of deflates them. So if you can just look into those, you will find that there's a greater improvement. And then the other discussions about salary increments will come. It would still come. I know it's also critical, but I'm saying just inputs to enable health practitioners to do their work. That's all. Is there anybody else?
Yes, Chair. Good afternoon.
Ke re re batla ba la arabe a dikhwetli. Wa itse gore wa e retsa so? Hangata ke lona batho ba ko bo rona, who complain gore e no a ho etsa le eng, but ha re discussing a le batle. Again. So are we utlweng when our managers, you know, say these are some of the things that we are doing, so that let's and go and advise your communities. I get it. Or hey, only pregnant. We must advise one another. We must advise in our families. We must advise in social platforms where we gather, so that we are more enlightened about some of these issues. Because if we don't do that, and you know who's dying the most, got the issues. Do you know? So, from these managers, some of lona mo, lena le wana ma ko bolona ba ile gore ba pregnant ba bangwe go rabile anwa ka o sa nwa kra hona le ntshwele ba re ke fetal alcohol syndrome agere wa o mongwe wa kra na le cerebral palsy e be le no a department in fades ke sepetlele. So we're trying to surface all of these issues agere. So let's ka fela mpelo agere, let's ka fela mpelo parliament e tlile for lona, we're here for you. So hale fela pelo la re makatsa agere re thomo tshowa le rona. So bua mme.
Ka leboga, Chairperson and other honorable members. I'm going to respond on the comments that were made earlier regarding the status A as well as the department's data on maternal mortality. So I just want to clarify for the chair and the members on the those two measurements. So the department collects data, routine data, through the DHIS Ebaholo, and that data uses a reference population of live births. Now, status A, on the other hand, uses population-based measurements. So status A uses the reference population here, people or women of reproductive age. So we're talking 15 to 49-year-olds. So there's a difference in the way we measure maternal mortality. So in the department, it will be maternal in-facility maternal mortality ratio. And then in at the population level, we'll measure the maternal mortality rate. So that's the difference. So the figures will never be the same in that regard. The aspect of the difference between the older Saving Mothers report and the DHIS, yes, we are aware of some of those particular discrepancies, Chairperson, and we have, as a department, been putting measures in place to improve our routine health information system data. And in that regard, you'd see, if you look also at the AGSA report, the previous report, which will, align to some great extent with the Saving Mothers report. You would see that the errors or the level of errors as far as material indicators like the maternal mortality, or child-related issues, the level of errors have decreased. The last aspect that I want to respond to, Chair, is in terms of, the comments and questions related to the need to integrate, child health services and mothers, because, when a mother dies, there's a lot of implications, not only for, for the mother, there's implications for the healthcare system in terms of trust. When people see that there's, maybe many more people dying, or mothers dying, they tend to, have lower confidence on the services. There's also economic, implications as well, even for the development of the country. And hence, from a policy perspective, Chair, the department for the 7th administration is still going to be pursuing as one of its priorities, the implementation of respectful maternity and childcare services. And our MEC have started implementing in the previous term interventions or strategies that are aimed at, addressing this priority area of maternal and child healthcare services. And we're pursuing these particular targets also in light of, the National Development Plan, because we basically are left with fewer years before 2030 to demonstrate as a country that we have, reduced our maternal mortality and child healthcare services. So I think, Chair, we will be given as a department an opportunity to come and present what the plans and commitments for this current term looks like. And, our communities will get to have an opportunity to see some of the interventions that MEC is going to be presenting that specifically speaks to how we're going to expand services for maternity as well as neonates, which we are having a problem around, and some of the equipment and staffing interventions that are going to be implemented in that light. Thank you so much.
Okay, thank you very much. Me mfigo allara. Diloze ungivil dedize mosona balonga je. Wala, mara it's okay.
I guess part of the problem, Chair, is responding and creating problems in the responses. We requested presentations to be made. So my question is, when you say you'll come back to present, when and where? Because that opportunity was given to today. We're not going to have another public engagement on the matter sooner. So why let's release the information then it's still going to come.
Should I respond,
Thanks,
Chair? Okay, thank you, sir. So these are priorities that are outlined in the Strat Plan and the APP that is yet to be tabled. So normally the processes of the legislature, you do give an opportunity to the department to go speak to the communities in terms of the budget vote, priorities that they're going to implement on a particular year. So that's what I was making reference to, Chair.
Okay. I think let's step off it. Is there any other manager?
Yes, please. Thank you, Chair, and good afternoon, colleagues. Thanks for the opportunity to make some comments and expand on some of the answers that have been given. There have been quite a number of changes that have happened over the years, particularly the way we do things in hospital and in the facilities. First, to comment on the fact that maternal mortality is usually seen as an obstetric or midwifery issue, but it goes well beyond that. It reflects society as a whole, socioeconomic issues, and within the health sector, it's actually a multidisciplinary issue. You need a lot of people within the obstetric community, as well as anesthetics, the medical department, surgical department. All these people contribute a lot to the outcomes of maternal mortalities. Flowing from that, I would say that, maternal mortality, this triennial thing which started in 1998, brought up a lot of information. And because of that, there was this cluster system that was instituted from about 2016 within the Gauteng province, led by Prof. Tauke. It has actually helped a lot, talking of in terms of recommendations, how things have gone in terms of improving the services. The cluster system has helped a lot in educating people, presenting our cases, and also helping to refer cases in between the facilities. Next is the M&Ms that we talk about. Maternal M&Ms have been going on for years, not only recently. Now, it concentrates only on, it's a once a month kind of thing that we do in the Raton, in the other hospitals. Now, imagine one meeting that is going for 2 hours, that's going to do statistics and also discuss cases. So we usually find ourselves not being able to discuss all the. So currently, our current HOD for Laraton, Dr. Moses, I don't think she's here. She's introduced this online meeting that we're having so that people don't have to come from, say, Carltonville Hospital to Laraton. When the case happens, they discuss timelessly so that everybody knows what happened. And because of that, it reaches out to everybody. It's online, therefore you are sitting in Yusudadu Hospital, you can still participate in the discussion. And I believe it is helping a lot in bringing out some of the deficiencies that we have in the system. I acknowledge that there are some challenges with the online, these meetings, especially as mentioned by one of the members here about M&Ms. M&M typically is expected to identify what went wrong and not who did wrong. The aim is to learn. However, it can turn out into a witch hunt and a kind of retribution of trying to pay back, try to penalize people and kind of things. So if the managers who organize these meetings stick to that principle, that the aim is to identify problems and not identify what went wrong and not who did wrong, then we'll go a long way. Over the years, when we talk of postpartum hemorrhage, we always talk about the uterus not contracting and things like that. With the explosion of cesarean sections that have happened, we all know about this. Caesareans are now in the regions of 40%, sometimes even 50% in some areas. And we have a new type of postpartum hemorrhage, which occurs due to cesarean section complications. And this happens, the more often you do a cesarean section, the more likely you're going to get one, mainly due to adhesions to bladder, to bowel, and other things. So a lot of the complications that the PPHs that you see in our maternal mortality are mainly because of this. So out of that, the cluster group came out with safe cesarean section techniques. And we had to monitor MOs when they were doing the cesarean sections, which to me has helped to improve outcomes a great deal.
Doctor, don't go too long.
No.
Yeah,
Briefly.
don't go too long.
Thank you.
It's okay.
I'll mention critical care, which I hope Chief is here. It has been a for us because our critical care facilities have not expanded over the years. There's still only 7 ICU beds, and we fight over these things. Sometimes we have to nurse patients who are ventilated outside the ICU with a lot of repercussions. Lastly, if you allow me.
Now you are surfacing problems and you are a health manager.
I'm a health manager, but I'm sorry.
Yeah, you see, my problem is that I don't expect you to service problems. You
No.
must tell us solutions, how you are escalating.
We have
for
escalated.
intervention.
No, these escalations we've done over the years whenever we report on
Yeah,
cases.
Please,
So
let's
there,
settle. I want you to have a dialogue. The district manager is there. Representatives from the province are also here because doing it in this platform is not taking us any way forward. I want us to go forward. You see,
okay.
Especially when you are a health manager yourself. You know, I understand if it was coming from any other of the stakeholders. They are not in the space you are in. You see, so maybe let's leave it at that. I want us to move.
Okay. Thank you. In that regard, I would like to make the last comment on certain equipments. Now we have ultrasound facilities in most of our facilities, and it's going to help us a lot in terms of all these things that we talk about. Early pregnancy detection, early pregnancy monitoring, it contributes a lot to identifying some of the problems. So I believe with this kind of thing, the government is on the right track in terms of helping to improve the mortality statistics. Thank you very much.
Thank you so much. Truly appreciate it. You want to come in, ma'am, or you are fine? Don't feel the pressure. You must not be intimidated. I know I've got an intimidating voice. If you want to speak, you are empowered.
Good afternoon, colleagues, everyone, and all protocol observed. My name is Dr. Panzu. I'm a medical manager in Leraton Hospital. My contribution at this juncture is just to say that I think critically we need to ensure that there's no moratorium in those areas. I'm talking about mother and child. You know, that doesn't help us. if we believe that mother and child is one of our priorities, there should never be a moratorium in those areas. So midwives that need to be replaced, they need to be replaced. Doctors working in that space need to be replaced. I'm thinking of specialists. I'm happy that Dr. Sarfo, who just spoke, alluded to the fact that midwives is key, but the doctors are also key. So when we do that, we should not forget that aspect. The ratio between health workers and patients, we need to reverse that ratio. It doesn't look good at this present moment, and unfortunately, it's also leading to the fatalities. Thank you.
So much. Truly appreciate it. I hope I'm not leaving out any of the managers who might want to express any views really. That wouldn't be our intention. You are also a critical stakeholder, by the way. You are a primary stakeholder who's coordinating the program, isn't it? So it does help to hear from you. And I'm happy that some of you even go as far as making admissions that there are instances where there are shortcomings, but this is the third plan to redress. We really want to appreciate that line of reasoning. I think it does takes us somewhere. Are we all fine? Okay. So thank you very much. So you can't come after the fact. Or it's like when the president has spoken, I want. So maybe that issue you can raise it with me, and then we can convey it. Ne? Maybe let's do it that way, because I'm afraid we might set the precedent. Then I know I may have said it with the gentleman, but I just gave him because he's young. He's young, so I just thought, let me not deny him the platform. Yeah? But thank you very much. I think we have reflected extensively on the subject. I know part of, let me stand up so that I show a bit of a reverence. What is it? Okay. Yeah, let me show a bit of reverence. I think in this slot of our program, you can hear me. Yeah, in this slot of the program, we were going to be joined by the MEC. But I did explain when we started that the MEC unfortunately has got a Premier's coordinating forum. So she's locked in that meeting because I just didn't want us to conclude and not have a way forward. These are critical inputs that you will have made. And so we had requested in that Mazibuko to record for us some of the immediate, intermediate tasks that needs to be looked into by the department. Of course, in other instances, the department has responded to some of the questions that you will have put forth. But I still believe there's always room to consider other things, with the hope that they may assist us to mitigate the obstinacy over some of the challenges that are plaguing the system. And ourselves as the committee would obviously use that framework of recorded items to say, has the department considered issues that would have been raised by stakeholders, And this goes beyond what makes a feature in the reports that you mentioned, Marus. So it goes beyond. It might be additional inputs that are intended solely to try to mitigate and turn around the situation, particularly because they are raised from those who are, at all of these service points. So it's not as if they are aloof. They are not oblivious to these realities. But they are diagnosing what they believe are system blind spots that the department may need to respond to. And I'll tell you, it's our sharp for overview so that they become our action plan. We need an action plan. Again, do you want to come up front or you can present from there? Yeah. You have another mic? Or should I give him this one? So Ndate Mazibu was just going to summatively present items which we believe must be crystallized into our action plan, which as the committee will monitor in our conversations with the department going forward. Again, thank you very much.
Thanks for the opportunity, Chair. Afternoon once more, colleagues. I'm just going to touch on those few recommendations, as Chair said. Apologies. I think one of the things that came out strongly is the issue of health education. Both the department has acknowledged that there is health education, and colleges also indicated that they do give health nurses the opportunity to.
Why is it earlier on no voluminous, man? You have got a stentorian voice.
Thank you, Chair. I think maybe give Mike. Unless give a Shop Stewart voice.
This mic.
Let me use your mic, Chair.
This one is prop.
Thank you, Chair. You see, there's a big difference now. As we are saying, issue of health education, there needs to be an improvement on how health education is given to the community members. And also there was a recommendation for the use of warbot teams to help identify the pregnant women and call them to our clinics. Communication was also highlighted, and also the issue of identifying problems from bottom up. Problems should be identified from bottom up, not from top to bottom. Those are some of the things that we've looked at. And the issue of rotation of nurses, the community has spoken very sharply against that. So the department needs to look at how are they going to mitigate against having to do that. And we have also seen that, let me see, or the issue of ESMO training. I think that those are low-lying fruits in terms of having to offer ESMO training to the ambulance services, our first responders, and making sure that it is rolled out at other facilities as well, because there was a concern, especially in Tshwane, to say that people are not aware of ESMO. And the department is also committed to circulating the Save Our Mothers report for those who are not having it. And the department has the responsibility to address the issue of shortage of staff, especially in particular those critical areas like our MOUs and other places. And there's recommendations as well to assist the nurses or healthcare workers with addressing some of the challenges of the areas in which they are working in that can be done by the department. And health education came out again, and then I'm also just going to highlight to say that there was a recommendation which came out to say previously people would have health education in between. I think women used to do exercises, antenatal classes, when I used to train as a nurse. So maybe you should look at introducing that again from the department, especially because we've got health promoters in the facilities. It can be easily done. And the issue of support for the nurses, not only nurses but healthcare workers, for debriefing. It also came out, and the department can also look in. They said they will look into that, but it's something that can be done. And there was an agreement as well, acknowledgement for collaboration with the department and pastors and bishops that they can be able to work together. Issue of IUCDs has been addressed, and training. Department needs to make sure that they are able to assist in terms of making sure that we've got trained midwives who are capacitated. And the delay in coming for late book, let's call it late bookings, it's also an issue that needs to be addressed by the department. As much as the department is saying they use social media, but there should be other ways that we encourage women to be able to come forward and be able to register their pregnancy so that we can address some of the challenges that we see that come with late bookings. And the CTOP facilities have been appreciated highly by members of the communities, especially, and then they also then says that we've got a challenge on how are we going to address those illegal termination of pregnancy centers. And then the department has that homework to go back and say, how do we tackle that? Because we've got this offering and yet we still have some of our patients going to illegal or backstreet abortion centers. And partnership, I think I also mentioned this, the partnership between private and public. Dr. De Villiers also mentioned to say that they look forward to partnering with the Department of Health. So we then need to have more of those partnerships between private nursing education centers and the department so that we can be able to produce more nurses. And more of those partnerships can also help as well, even in the clinical areas, offering services, maternity services to our people. And I think, yeah, mostly there would be that. I think, yep. Thank you for the opportunity, Chair.
Thank you so much. Yeah. So it might appear a long list, but I'll tell you, we will distill it and catalog it properly and aggregate it into different, yeah, I'm trying to get a suitable word. Categories. Maybe let's just say categories. Because earlier in the presentation, Mzondi, you spoke about a policy. I'm not sure which policy is that. Is there a policy development process? Oh no, it's the Ombu thing. But of course, from time to time, the department does reflect on their own strategies and policies. We might then use that to inform the content of those reflections, you know. So maybe let's work on it together with me, Mukonoto, Lemme Mzondi, so that we clean it up, crystallize it into something that would be more presentable for the consumption of the department. I get it. So that you know, these were things that were raised. Public participation must always be appealing, you know. It is the men and women who are the end users of our facilities that must be listened to in the most. And that is the way in which you build the legitimacy in the governance of our state institutions. But having said that, allow me to thank all of you, wonderful people really, of the Lord, for your steadfastness of remaining the course. Ordinarily what we see is that when we have got these kinds of engagements, only two types of people who make an appearance in them. There are those who come to pass time, right? Shop around, maybe we lenga kranyana le dijonyana. I get it. Then there are those who want to impact a meaningful change. And I want to thank those whose commitment to impact change is resolute. You might not be personally afflicted by all of these things, but for the fact that you are active in your own communities and may be aware of cases of people who might have suffered some injuries, others who might lost their lives, you have taken a keener interest and came closer. We really want to appreciate you. Because it is only in that way that we can propel our own society to be more advanced in responding to the challenges that besets this area of a medical practice. Because if you don't do that, where do you think these solutions are going to come from? Decision makers, policy makers, often at times suffer what I call a rationalization fatigue. And it is that, at that critical point, that community stakeholders must rise to say, hey, ela la bona ele. Because le try to do things in this particular fashion. And in no one sector of our society stagnates. All sectors of society evolve. Because there's newer data, there's newer information, there's newer practices, there's newer benchmarks. Again, there are newer contrasts, there are new ideas, there are new innovations. But all of those ideas, all of those innovations, they are not self-made. They come from people. Some of them who may not necessarily be professionals in that space, but may be ordinary men and women who have learned through the experience of others. And that's how the world has been advanced. Not everything that moves in the world was created or idealized by people who knew what they were doing at the time. Some other innovations are accidental, but they have helped humanity to advance. So we really want to appreciate all of you for responding positively to the call by the committee to come and engage, to come and hold the department accountable on their overall strategic management of maternal health services. And we're leaving here a bit more enlightened. We're leaving here with the takeaways around what we commit. I usually say our mandate comes from yourselves as members of these communities. Because right now are not health pundits. We must listen to you on issues that you want to be represented in the highest echelons of governance. Again, so rato le leboa ka mantswao re ke weekend a le neng le khotso ya modimo re ke batla gore moruta ke tsore ko mofeng o mo senior between bishop le reverend. You will advise, again. Yeah, you will advise. I don't want to discriminate. Mare nna ke le leboile, committee le leboile, ke le leboetse even on behalf of the department and the MEC who couldn't join us. I know there's a food, okay, but they've requested that you remain, and then I think they'll serve from where you are. So I remove, they will serve you from where you are. I get it. So once more, thank you very much. Enjoy the rest of the day, the rest of the weekend. Allow me to hand over to the bishop to close it. Or Reverend, when I got a go a attire thing, Bishop Apara and try. And thank you very much.
Sitting as Salo or Bishop Tumelingwengwe. The elder sent the younger one. Bishop Tumelingwengwe. Shall we stand on our feet? Is it okay? And just bow our heads. Our Father and our God, we love you. We appreciate you. We worship you. We are doing this prayer on behalf of every religious leader in Westland, whether you are Christian, Rastafarian, Islam, or the traditional health practitioner, or any other faith group you belong to. We come before you because we realize there's one thing we all have in common: a living God. We are here to thank you for what transpired today. It is not always positive interactions between government and her people. The fact that we had a smooth, engaging debate from the morning till now, it is because of your kindness and your love. We thank you for this committee, O Lord. We thank you for the chairperson, Honorable Ezra Litswalo. We thank you for everyone serving there in that committee from different portfolios. We thank you for all the political parties on that table, O Lord. We thank you that in South Africa, at this moment, we have a government of national unity, where as different as they are, they can unite on things affecting our society. We thank you for these, Father God, leaders from different spheres of government that are here, who have left their very important portfolios to be here and share their wisdom with us, Lord. We thank for those from the learning institutions who are also here, oh Lord, to share their wisdom and advice unto us. We thank you for the stakeholders in the community, oh Lord, who are also here. Whether we say, like they once said in the book of Ecclesiastes, that now, when everything is said and done, when everything has been said and done, let us fear God, because it's the whole duty of man. Because at the end of the day, everything shall be brought to light, whether good or evil. We say, God bless South Africa. God bless our province. God bless our region. And God bless every single person in this room. May you look at our lives, that because we sacrifice everything to be here, oh Lord, may you look at their lives, and whatever thing that is not conversant with who you are, may you just correct it, because you are the Lord God of order. Sicknesses and maternal mortalities are not things from you. Therefore, Lord, as we embark on this journey to unite and discuss these things, we may not just the leader from Dinosa just summarize an action plan. May it be implemented. May we be doers of what we say we're going to do, not just talkers. Father God, we pray a good life upon us all. We even pray for the refreshment that are going to be served, that they may be soulful unto us. We pray and believe that every one of us will be better off because you live. In Christ's name we pray and believe. Amen.
Amen. Thank you, leadership. Thank you, leadership. Oh.